Welcome to the biggest and most awaited academic event of the year, the DAMS DVT 2023. A great and a magnificent academic event to help all the students to achieve milestones in their academic journey. We are going to start very soon, and our first speaker for the day is a wonderful academician, a great motivator, a guiding star in the lives of millions of young doctors of India. Not just in the country, but she is a well-known name and sought-after teacher in the entire world. I'm talking about Dr. Deepti Bahl. Welcome. She is our first speaker today. Dr. Deepti Bahl has done her MBBS from Lady Hardinge Medical College, MS Obs and Gynae from Lady Hardinge Medical College, New Delhi. She is a senior consultant, OBGY and infertility. Worked at LHMC and Fortis, director at DAMS eMedicos. We welcome you, ma'am. Over to you.
Hanji, everyone, a very good morning to everyone, and it's a pleasure to be here for yet another session of DAMS Visual Treat. Believe me, this is like, a place of worship for us. This is a place where, we have different identities. This is a place we value so much, because this place gives us an opportunity to be a part of your life. And I am greatly thankful to each and every doctor who has joined us today. With folded hands, I am paying you gratitude to make DAMS a part of your journey. Through you, we at DAMS are hoping to create a legacy, and you are going to represent us in future. And we are proudly able to say that each one of you has immense capability and potential, and you have this immense enthusiasm to have a bigger impact in your patients, in the society in general. So I am here today, with folded hands, thanking you to give me an opportunity to be a part of your journey. I can see the chat box firing, right? And that's what I want from all of you in this session today. It is purely going to be a revision session. Don't worry, there is nothing unique and there are no researches that we're going to bombard at you. It is going to be the most high-yielding content that we are going to bring to your doorstep to ensure that you don't need anything else for revision. DAMS as a team has put in a lot of effort from behind the scenes to everyone in front of the scenes. And again, with folded hands, I say, because the entire India is watching us today, it's a huge response. We are going to try our best, but if here and there are small glitches, please forgive us. But we as a team are going to bring us our best. Our motive and goal is to help you in your journey, to accelerate your process to your success. That's why we are here, right? And we are going to ensure that your every moment that you're giving to us, we make it special. So today I am going to be thankful to God Almighty to give me this opportunity, and thankful to all my dear students who have faith in us, right? Now with this note, I'm going to just begin with this session for today. As I said, my goal is that you should not be needing anything else apart from the DAMS Visual Treat. You will get the videos, you will get the annotated PDF, you will get everything. You just have to sit here and you have to try and get yourself involved. Keep the energy running high, right? Try and recall. Most of the things are already written here. What you have to do is only speak out few keywords. It's a game of keywords, right? And that is what my purpose is, that when you go to the real exam as well, the keywords should click to you. You should be able to get it right there and then, and you should be able to put things across, right? So everyone, are you ready for this session? Yes, are you ready for the session? Okay, so as I said, I'm just going to begin with obstetrics first, and then we are going to go on to gynecology, and then Dr. Anil is going to cover all the images in obs and gynae for you, right? So everyone, get yourself ready. I hope the booklets are with you. Let's fire. Let's start. Okay. So yes, all fine. Get set, go. The audio video is good on my app as well. I can see that. Just ensure that your own sound in your, phone is not on the mute mode. Increase the sound at your personal level. Everything is good here, right? Okay. Chalo. So let's begin with this. And as I said, we are going to begin with some basics and gradually go on to specific topics. I want you all to keep giving me the keywords. The fill in the blanks are there and you have to come up with the keywords. Okay, so let's look at this one. HCG is produced by what cells? Yes, so it is going to be syncytiotropoblast, right? Also remember, it is a glycoprotein hormone. That's important, okay? And when we talk about it, remember, it has a doubling time of 48 hours for a live intrauterine pregnancy, okay? And when we talk about HCG, please remember the very, very important thing. It is similar to these all hormones, okay? So LH, FSH and TSH. But when we have to mark one answer, the answer is luteinizing hormone, right? Please remember, when we talk about LH, FSH and TSH, the unit that is visible, that is similar is alpha subunit, okay? And which unit is specific? It is the beta subunit, okay? The beta subunit is the specific one, but beta subunit resembles closely to the hormone LH. So that is why when we say single best, answer is going to be the luteinizing hormone. Very, very important. It maintains the corpus luteum of pregnancy up to 8 weeks. Okay, up to 8 weeks, it is going to maintain the corpus luteum of pregnancy. And if we ask you how early, okay, how early is HCG produced? Yes, so uska bhi answer 8 hai, but that is going to be produced 8 days after fertilization, right? So it is produced 8 days after fertilization or after ovulation, right? Okay, now let's look at this. The next one is HCG levels are high in. So the first important one that you should know is GTD, okay, gestational trophoblastic disease, okay, gestational trophoblastic disease, which you popularly know as molar pregnancy, okay, which you popularly know as molar pregnancy. All right, hold on. For some of you, if it's a black screen, they are there. Did you try exiting it? Yes, just try and exit the window once, okay, and join back. Join back. All right, don't worry everyone, just don't worry. I'm going to take 5-10 minutes. We'll start after 5-10 minutes. Don't exit, just wait for 5 minutes. I'm also waiting for 5 minutes and we'll restart, okay? So I've just done one small paragraph. Don't worry, okay? As I said, the entire India has joined in. There is a huge load, right? And although the yes, so we are upgrading the server even further. So just hold on, just 5 minutes and we're going to start off, okay? Just hold on, right? Breath, everyone, relax, and I'm going to start off right from the beginning. I just did a couple of lines, nothing more, so don't worry, okay? All okay now? Yes, so I'm back. Don't worry, I'm right here. ठीक है, relax करो सारे बच्चे. हाँ जी, I think only for some of you it is a black screen now. Stop typing. type when, when I'm asking you questions. Stop typing, and I think for most of you it's working now. Just a couple of you have some issue. They are seeing it. Okay. Yes. Once you're in, don't worry. It'll be just great, right? It's just that there's a huge load all across India, right? So we are, yes. So are we good to start? White screen? I should be there on the screen. Okay. For anyone who has a white or a black screen, just exit once and re-enter. It should be fine now. For most of the people, it's turning out to be fine now. Okay? Yes, everyone good to go? Okay, so till then, I am just going to repeat what I did very quickly. There were just 4 lines. So as I said, all of you are only going to type the answers that I am looking for, right? Chalo. Okay, so all good, all good. Okay, now focus on the padhai, right? I want everyone to focus now. Let's get back our attention. Let's close our eyes, take a deep breath, smile, and let's start off. We have to start everything off with a happy face, right? As I said, we have to be grateful for everything that we have, right? And you're going to get more, right? So if you really want more, you all need to smile and send me a picture later that you were smiling. Yes? Okay, so I'm going to just begin with where I started. I just did a few lines. Don't worry, everything would be available to you after the sessions, the video, the annotated PDF. You can watch the video as number of times as you want. Okay? Chalo. So now, let's do this. So we were talking about some reproductive basics. It's only some fill in the blanks, and you have to give me answers for those fill in the blanks. Right? So we just did these 4 lines. Okay? So HCG is produced by, we said, syncytial trophoblast. And I said, please remember it is a glycoprotein hormone. The doubling time I said is 48 hours, but that is for a live intrauterine pregnancy. Then we said, remember, HCG is similar to 3 other hormones. They are LH, FSH, and TSH. The single best answer is going to be LH. Okay? Specific subunit is beta subunit. So please remember, all the pregnancy tests are going to be based on the beta subunit. And I said, although the beta subunit is specific, it is quite similar to beta of LH. That is why the single best answer to what it is similar to is LH. Okay. Now, please remember I said HCG maintains corpus luteum up to 8 weeks. And how early is HCG produced? I said uska bhi answer 8 hai, but it is going to be 8 days after fertilization. Okay. Then what are the conditions where HCG is higher than expected? Okay. So the first fill in the blank is gestational trophoblastic disease, or something that you popularly know as molar pregnancy. The next important one is Down's syndrome. The other important ones are written there, right? For example, multifetal pregnancy. What is erythroblastosis fetalis? This is hydrops fetalis. And what is the reason for high HCG? What is the reason? The reason is big placenta. So please remember, wherever the placenta is big, there is a placentomegaly, HCG levels are higher. Okay. Now, what are the conditions where they are lower? So we can call it as a non-viable pregnancy, which is popularly called as what? Abortion, right? So in a non-viable pregnancy, the levels are going to be lower. In ectopic pregnancy, the levels are going to be lower. Okay. Trisomy 18 is different from trisomy 21. So please remember, in 21 it's high, in 18 it is low. Blighted ovum, which means there is a sac with no yolk sac or embryo. That's what is a blighted ovum, right? So in a blighted ovum, there is again HCG levels which are going to be lower, right? Now, The next important hormone that you should know at least something about is HPL. What is the new name of HPL? Come on, tell me. I'm sure you all can give me the answer. It is HCS. Okay? Human chorionic somatomammotrophine. Right? So human chorionic somatomammotrophine is the new name of HPL. Human placental lactogen, right? So please remember this. This is just the other name. Okay, now quickly. It is also produced by syncytiotrophoblast as early as 3 weeks of period of gestation, right? So when you write weeks, it is from POG. Now, what is the most important function of HPL? The function is endocrine. And what endocrine function? Insulin resistance. Okay, so the main function is endocrine and that is insulin resistance, right? Please remember it is produced maximum by the placenta in the 3rd trimester, right? So as the placenta gets bigger, it is going to produce more HPL and typically the values are highest at around 36 weeks, okay, 36 weeks. Now, very, very essential. Please remember when we talk about fetal growth, can you tell me which hormone is responsible for it? So when we talk about fetal growth, the single best answer is insulin-like growth factors, okay? It is insulin-like growth factors. Then progesterone. It is produced by corpus luteum up to 8 weeks. That's what I said. And after 8 weeks, it is going to be produced by the placenta, okay? Now, the important function of progesterone is, who's going to tell me what is the function? Yes, it is going to decrease what? Uterine contractions. Okay, it is going to decrease uterine contractions. That is why we use it for prophylaxis of what? Preterm labor. Right? This is why you use it for prophylaxis of preterm labor. Already written there, right? Okay, now, morula. Some things about early pregnancy are always asked in your NEET PG exams. For example, morula enters the uterine cavity on, who's going to tell me quickly? Let's see. Let's type the answers. Yes? You have to check your local connection, bache. Now it's working here and for most of us it is working fine. Right? Yes, morula enters the uterine cavity on day 4. And when you say day 4, it is post-fertilization. And in what cell stage? In 16 cell stage. Okay. Morula eventually is going to form the blastocyst. When is blastocyst formed? Come on. Very good. Excellent. I can see everybody can recall and that's the best thing. Day 5. This is also when zona pellucida is lost. So if they ask you about zona hatching, okay, the answer for zona hatching or when is zona pellucida lost is also going to be day 5, right? Perfect. Excellent. Excellent. Everyone, good going. Implantation, come on, tell me, when does it begin? Implantation begins on day 6. The range is 6 to 7, but the single best answer, wherever it is a single best answer, I'm going to circle it for you, right? Day 6. When is it completed? Day 10. The range can be day 10 or 11. The single best answer is day 10. Perfect. Let's go on to the next one. Now, no fetal anomalies are seen if the exposure is less than how much? 5 rads. Okay? 5 rads or 0.05 grays, right? And what is the time for greatest exposure? Please understand here, I am asking only about ionizing radiation. So for ionizing radiation, the important time is 8 to 15 weeks. Okay, 8 to 15 weeks. Please remember all diagnostic radiation or modalities, whether it is an X-ray, right, or multiple X-rays. So when you talk about all diagnostic modalities, they will lead to an exposure which is less than 5 rads. So if there is an exposure, your answer has to be continue the pregnancy, right? So if there is an accidental exposure, your answer is going to be what? Yes. Continue the pregnancy and follow up with ultrasound. So you have to continue the pregnancy and follow up with ultrasound. Okay. Then let's move on to the next one. The next one is going to be specially important about certain syndromes. So the first one is going to be fetal alcohol syndrome, that is already given to you. I want you to know about diethylstilbestrol. So remember, it causes a T-shaped uterine cavity and it is responsible for clear cell cancer of vagina. And you have to remember that clear cell cancer is a type of adenocarcinoma. So sometimes they don't give clear cell cancer, they will write adenocarcinoma, and that's what you are going to mark. Okay. Lithium, I think everybody knows. What is it going to do? Epstein's anomaly. Perfect. Very good going, everyone. Okay. Thalidomide, remember, it is phocomelia. Valproate, I have already given it to you. The most important are neural tube defects, especially spina bifida. And please remember, valproate is category X, right? So valproate is category X. Perfect. Warfarin, you have to know the term chondrodysplasia punctata, right? Chondrodysplasia punctata. Perfect. And what part especially we are going to talk about? We are going to talk about nasal bone. So there is going to be hypoplasia of the nasal bone. Perfect. Very good. Can you tell me what will happen if you give indomethacin beyond 32 weeks? Yes, it is going to cause premature closure of ductus arteriosus, right? So premature closure of ductus arteriosus. Okay? Perfect. Then vaccines which are contraindicated, super important. Which ones? Remember MMR, remember varicella, and remember HPV. Please remember, if there is exposure to varicella, what should the pregnant woman take? What should she take? She will take Varizig, right? Not the vaccine. She has to be given the immunoglobulin. So the answer is going to be Varizig. Perfect. Very good. Now let's move on to early development. Paramesonephric ducts are also called as what? Yes, they are called as Mullerian ducts, right? So Y chromosome, what does it secrete which causes disappearance of the Mullerian ducts? It is going to be Mullerian inhibiting substance, right? MIS. Also, can you tell me on which chromosome is the gene located? Yes. So it is going to be chromosome 19, right? Chromosome 19. Also remember, MIS is same as AMH, okay? Anti-Mullerian hormone and MIS are same. I'm going to talk more about AMH later. Chromosome 12 पे उसका receptor होता है बेटा. Gene for receptor, right? So this, it is present on chromosome 19, but the gene for the receptor of this is chromosome 12. Okay? Gene for receptor is chromosome 12. MIS is chromosome 19. Okay? Chalo. Mesonephric ducts are Wolffian ducts. Dash stimulation is required. What is the hormone that acts on the Wolffian ducts? Yes, it is going to be testosterone. Right? Now please remember, this Wolffian duct is going to form what? Male internal genitalia. Right? It is going to form the male internal genitalia. Mnemonic is seed. We have given to you the seed. Remember, seminal vesicles, epididymis, efferent ducts, and ductus deferens. Very good. I can see everybody can recall. Genuine recall karo, class se hi yaad karke jao, and I'm sure you're going to do well. Okay? Chalo. Male external genitalia, right? What is the stimulus required? Diethylstilbestrol, okay? Diethylstilbestrol. So please remember, when is this differentiation going to happen? 12 to 14 weeks. Why is it a range? It begins at 12 weeks. Complete differentiation happens by 14 weeks. So male and female begins by 12. Complete differentiation by 14 weeks. Okay, from what structure do the gonads develop? Remember, this is called as genital ridge, not tubercle. Okay, so this will be called as genital ridge. Good going, everyone. Excellent. Dihydrotestosterone B2. Dihydrotestosterone. Okay. Now, please. Oh, I am sorry. I did that mistake. Right. DHT. Dihydrotestosterone. Okay. I am sure you all remember the enzyme testosterone to dihydrotestosterone. Yes. 5-alpha reductase. Right. So, 5-alpha reductase. Okay. Testes are formed by, remember, 7 weeks. So we say the gonads remain bipotential till 7 weeks because testes will form at 7 and ovaries will form by 8 weeks. So if we ask you bipotential gonad, by 7 till 7 weeks, it's bipotential. Okay. Presence of dash is what is required for formation of testes. I'm sure you all know. Yes, SRY gene. Where is it located? This is located on the short arm. Okay, on the short arm of chromosome Y. Right, so SRY region on the short arm of chromosome Y. Excellent, very good. Chalo. Physiological changes. We are going to do the most important ones. Not everything can be done towards the end, but the most important ones have to be done. Okay, let's do this. Please remember, arterial, when you talk about blood pressure, both systolic and diastolic fall. So can you tell me what will happen to peripheral vascular resistance? Yes, peripheral vascular resistance is going to decrease. Remember, diastolic blood pressure falls more than systolic blood pressure, right? So DBP falls more than the systolic. Okay. Cardiac output is lowest in the supine position. Who is going to tell me the reason why? Everybody has to do active recall. Are you with me? How is the Josh? Tell me. Are you with me? How is the Josh? Yes? Good going, everyone? I am glad that you're all able to recall. It's just one words, but they're going to be the most important keywords for you. I'm just building momentum. I will sometimes increase the speed, sometimes decrease. We have to build the momentum. So how's the Josh, everyone? Hi, sir. Yes, sir. Keep going, keep going, keep going. Excellent. I want that you should do OBGY ka revision today itself. I will teach you how to do obs and gynae entire in 4.5 hours. Okay, that's how it is going to be. That's how you should do it even close to the exam. Ready, everyone? Yes, perfect. Yes, because of IVC compression. Then is cardiac output highest? Immediate postpartum. Right, immediate postpartum followed by during second stage of labor followed by 32 weeks. Remember, this would also be the order for heart failure. Okay? Systolic murmurs are physiological. Up to what grade? Come on, tell me. Yes, up to grade 2 they are physiological. Diastolic murmurs, please remember, are physiological in only 20%. So mostly they are pathological, so they should be investigated. But they can be physiological in up to 20% of women. But in most women, they are pathological. Very good. I am so happy with everyone. Aboli, Pranjali, okay, great going. Chalo. Hematological karte hain. RBCs का mass increase होता है, right? But what happens to hemoglobin and hematocrit? They are going to decrease. This is because of major water retention and expansion of plasma volume, right? So there is expansion of the plasma volume, which is much more, right? Can you tell me the cutoff for anemia? Hemoglobin less than 11 gram%. And what about hematocrit? What about hematocrit? Hematocrit less than 33%. Okay. What happens to ESR? Increases. Primarily because of the effect on what? Increase in fibrinogen. As you do DVT, आज आपको realize होगा that most of your INICT MCQs were also from the DVT itself, and the same thing will happen with NEET PG. If you do the DVT booklet the way we are doing it 2 to 3 times, you will not need anything else, not just for DVT, but also for upcoming INICT. You will realize everything has come from DVT even in the past, right? Let's do this now. Okay, tidal volume increases, minute ventilation increases, respiratory rate is important, it shows no change. Okay, residual volume as well as reserve volume are going to decrease. Okay, so residual and reserve volume going to decrease. PO2 increases, PCO2 decreases. So there is a, remember, compensated respiratory alkalosis. Why do we say compensated? Because pH shows no change. Okay, so it is a compensated respiratory alkalosis. What happens to total lung capacity? The best answer is no change. There is a very, very slight fall, but the best answer will be no change. Is that clear to everyone? Great going. Excellent, everybody. Renal. What happens to ureters? The ureters are going to show dilatation. And remember, the right side is more than left side. What is the reason for dilatation? The reason is progesterone. I have repeatedly taught you, whenever they ask you why this is happening, why that is happening in pregnancy, mostly the answer is progesterone. I'll tell you where the answer is estrogen. But if we ask you why is right more than left, what is the explanation for this? The explanation for this is dextrorotation of uterus. Okay, dextrorotation of the uterus. Very good. Tum sab padkar aaye ho. Do you even need me? You are like firing the chat box. Do you need me? Should I go? Will you do it on your own? Okay, GFR is going to increase, and this increases by 50%. Okay, what will this cause? Come on, tell me. This causes serum creatinine, blood urea nitrogen, as well as BUN to decrease. Okay, everything is going to decrease. Is that clear to everyone? Perfect. Very good. Very, very important. Pituitary size is going to increase by 130%. Huge increase. So now prolactin levels, will they be highest in pregnancy or after delivery? They are highest in the 3rd trimester, and the levels will fall by 50% after delivery. Okay, the levels will fall by 50% after delivery. Okay, breast milk production still is not going to happen. Why? Because of negative feedback of progesterone and estrogen on receptors on the breast tissue. But if we have to mark one answer, is it progesterone or estrogen? Always, I said, when you have to mark, go with progesterone. Okay, both are contributing, but single best will be progesterone. Okay, what is the first stimulus for initiation of lactation after delivery? Who is going to tell me? Yes, it will be sudden fall of P and E. Again, the single best answer will be progesterone. Circle means single best answer. Okay? What is the cause of lactational amenorrhea? Negative feedback of prolactin on GnRH. Okay? Negative feedback of prolactin on GnRH. Okay. In which syndrome there is failure of lactation? NEET PG ka favorite MCQ. What is the answer? Sheehan's. Yes. Please remember, the first symptom is failure of lactation followed by amenorrhea. But if we ask you the first hormone which declines, what is the answer for the first hormone? Growth hormone. Okay. First hormone पूछेंगे तो growth hormone. Great. Estrogen causes increase in thyroid binding globulin. Very, very important. So please remember, it is the total T3, T4 which increase. But what happens to free T3, T4? No change. What happens to TSH? No change. So pregnancy is a euthyroid state. Excellent. आपको सब आता है यार, आप लोग सब खुदा हो. You're all gods. हाँ, so good going, good going. Okay. Drug of choice for hyperthyroidism in the first trimester. Propyl thiouracil. In second and third, methimazole. But please remember, these drugs cross placenta and they can cause fetal hypothyroidism. They can even cause fetal goiter. And what can methimazole do? Yes, aplasia cutis. Okay, aplasia cutis. Chalo. Now, very, very important. Sare skin changes. Although the single best answer for hormonal or all changes is progesterone. But when we talk about skin changes, they are because of estrogen. When we talk about thyroid changes, they are because of estrogen. When we talk about water retention, that is also because of estrogen. So these three things are because of estrogen. Okay? Now, can you tell me, pigmentation, as I said, I should have written it here, is because of estrogen. Who is going to tell me what line runs from xiphisternum, which is a pigmented line? Linea. What is the name? Jaldi batao. Is it linea? Yes, it has to be linea nigra, not alba. Okay, it has to be linea nigra. Perfect. Very important, especially for NEET PG. What is pregnancy tumor? It is also called as pyogenic granuloma, also called as granuloma gravidarum. What is this? Granulation tissue under the effect of estrogen. It's a vascular granulation tissue. It's not a tumor. Okay, it's a false name. This is not a tumor. Okay, the management is conservative. It looks like a tumor. It is a vascular granulation tissue. Okay, what are the extra calories required in pregnancy? The general answer is 350 kilocals. But please remember, only and only if they specially ask about first trimester, then you will say no extra calorie. Otherwise, the general answer is going to be 350 kilocals. Okay. Injection TD1 is given at the first antenatal visit. After how much time do you give the second dose? 4 weeks, right? After the second dose is going to be given after 4 weeks. Please remember, booster kab dete hain? If pregnancy is within 3 years of previous immunized pregnancy, right? So only if it is within 3 years, then you will give the booster. Shabash. Excellent. So I'm going to clap for all of you. Good going to all the bachas. I'm proud of all of you. Karte raho, badhte raho. Okay, perfect. Folic acid dose. Kitni hoti hai in the first trimester? 0.4 milligrams. Yes, 0.4 milligrams. But if the patient comes beyond 12 weeks, what are you going to give? You are going to give iron folic acid tablet. Who is going to tell me what are the contents? 60 milligrams of iron. Okay, after 12 weeks, we are going to put them on IFA tab. 60 milligrams of iron with 0.5 milligrams of folic acid. Okay, plus to all patients who come to us beyond 12 weeks, what are you going to do? You are also going to give them calcium tab. How many milligram? 500 milligram. Twice a day. Tab albendazole has to be given everyone. Tell me the strength. 400 milligram. But it has to be a single dose. SD matlab single dose. Okay. Tell me, what is the FA dose for previous neural tube defects and women on anti-epileptics? Here the answer will become 4 milligrams, not 0.4. Shabash. What investigations are must do at the first antenatal visit? So, hemoglobin, blood group and RH typing, HIV, VDRL. Are you supposed to do a 2-hour OGTT, that is DIPSI test? Yes, it has to be done at the first antenatal visit itself. Urine dipstick करना है, HBS antigen भी करना होता है, but please remember HBS antigen is not mandatory. Okay, it is not mandatory but usually advised for all women. Okay, quickly. Minimum number of antenatal visits as per Government of India, 4. As per WHO, 8. Okay, as per WHO, 8. Okay. Gravida is total number of times the woman has been pregnant. So, do you include current pregnancy? Yes. Include current pregnancy. Okay, include current pregnancy. Parity, do you include current pregnancy? No. Current pregnancy is not included in the parity, right? Please remember L is currently living children. It's if a child was stillbirth. Please remember it is counted in parity but not counted in L. Okay, so stillbirth will be counted in parity, not counted in L. Is that clear? So some very, very basic things, but you are not going to do them wrong. They are PYQs. Good to go, everyone. Are you with me? Come on. If you are with me, send me a thumbs up. If you are with me, send me a thumbs up. Good to go, everybody. Okay, also, viability 28 weeks, Disha. Viability 28 weeks, bacha. Okay, are you enjoying this? I want to know this. Do you think this is effective revision? Yes? Are you all able to recall things? Yes? Perfect. Tell me, are you able to recall? Is it building your confidence that this is the only thing you need? Yes or no? Yes. Right? So this is the only thing we will need. Alright? I assure you that. Just do your DVT and you are sorted. Revise it 2 to 3 times. Perfect. Chalo, aage badhte hain. Ultrasound in pregnancy, very, very important. First trimester, what is the best parameter? Yes, it is going to be crown rump length. It is going to be crown rump length. And what is the ideal time to do it? 7 to 9 weeks. Although we can do it up to 14 weeks. But the best time is 7 to 9. Beyond 14 weeks, single best parameter is BPD. But please remember, beyond 14, combined parameters are going to be better than BPD, right? Combined parameters will be better than BPD. Perfect. Very good. Chalo. Super, super important. What are the uses of first trimester ultrasound? No, Mohit, 300 पुराना आंसर था बच्चे, अभी आंसर 350 है मोहित. ठीक है, चलो. Gestational age, इसके अलावा fetal viability, which means when you say fetal viability, it means cardiac activity. Suspected ectopic or any woman who comes to us with pain. Then discrepancy between uterine size, which means we include molar, we include multifetal. Okay, what else? If it is a twin pregnancy, chorionicity, right? Chorionicity, number of fetus, right? Then bleeding, any patient who comes with bleeding, which means all cases of suspected abortions, you should do an ultrasound. Then, yes, to assist in certain procedures like nuchal translucency, like chorionic villus sampling. Quickly tell me, which is the only GCA, right? Only GCA which can be picked up or diagnosed in first trimester. Which is that? Right, this is going to be anencephaly. Anencephaly is the only anomaly. Otherwise, first trimester scan is not for anomalies. Okay, it's not for anomalies, right? No, diagnosis of Downs is never on ultrasound. Please don't make that mistake. Okay, chalo. Very, very important. Combined test. is dual plus NT scan. When do you do it? 11 to 13 weeks. If NT is increased, it should be followed up with karyotyping. This is the best answer and it's very important. You follow it up with karyotyping. Okay? Diagnostic test for karyotyping in the first trimester. Chorionic villus sampling. Right? Okay. Quad test. What are the components? 3 components are already written. The 4th one is inhibin A. It's A and not B. GCA bacha is gross congenital anomaly, Rajay. Okay, gross congenital anomaly. Okay, who is going to tell me the components of dual test? So dual is done between 11 to 13. What are the components? HCG and PAP-A. Remember, PAP-A will be less than expected and HCG will be more than expected. Okay. What is the ideal time for nuchal translucency? 11 to 13 plus 6. Okay. 11 to 13 plus 6. Thickened NT. What is the most important association of thick NT or increased NT? The most important association is, yes, aneuploidy. And within aneuploidy, which is the most important one? Trisomy 21 followed by monosomy X. Shabash. But please remember, it is what is associated with cardiovascular anomalies. So if karyotype is normal, then you should think of cardiovascular anomalies. Okay. What is the cutoff value? More than or equal to 3 mm, more than or equal to 3 mm. Okay. CVS, the procedure has to be done beyond 10 weeks, but we will ask you when is it done most commonly. Then 11 to 13 weeks. Yes. Okay. If you do it at less than 9, what will happen? Fetal limb defects. Okay. What will happen? Fetal limb defects. Okay, quad test we all know, but please remember you can do it anywhere between 15 to 22 weeks. Most commonly done between 16 to 18 weeks. Okay, most commonly 16 to 18. We already know alpha fetoprotein and UE3 are decreased. Which ones are high? HCG and inhibin A. They are going to be higher than expected. Okay. Triple test, which is not included. ध्यान से पढ़ना है. Triple test में क्या नहीं होता? It does not include inhibin A. What are the other names for triple test? Yes, it is also called as BART test. Also called as Kettering test. They are other names for triple test. This is also done between 15 to 22. But which one do we prefer doing? Quad. Because it has higher sensitivity. Okay. Because it has higher sensitivity. Shabash, shabash, shabash. Okay. You are getting me excited because you are answering everything. Now what do I do? Where does ma'am go? Okay. Amniocentesis. It is, please remember, a diagnostic procedure, but it has to be done after 15 weeks. Inhibin B की बातें non-pregnancy में करेंगे श्याम. We will talk about inhibin B when you talk about, gynecology. But for OBS, remember, it is inhibin A. Okay. Most commonly, when do you do amnio? 16 to 18 weeks. Most commonly this. What are you taking out? Amniocytes and dermal fibroblast. Important है. ठीक है? What is early amnio? Early amnio is no longer done, but this is if you do it between 11 to 14 weeks, then you say it is early amnio. Okay. Level 2 ultrasound is called as also TIFA, targeted imaging for fetal anomalies. Okay. So targeted imaging for fetal anomalies. It is mainly done for, if you have to give one answer, gross congenital anomaly. But please remember, second trimester ultrasound is also the best time to look for what else? cervical length assessment, right? So it is a good time to look for cervical length. Also, you will start looking at amniotic fluid, and you will also start looking at placental location. So we will also focus on these things, and definitely we will start doing fetal biometry. We have to keep track on baby's growth, right? So these are the things we also stand for. Okay, right. No, NT लिखा था ऊपर बच्चे, nuchal fold thickness अलग है. It is a soft marker. It is done in the second trimester. Don't focus on unique things. Please focus on common things and don't do common things wrong. Okay. Remember, level 2 can be done anywhere between 18 to 22. What about fetal echocardiography? Fetal echo also between 18 to 22 weeks. Okay. Now, important DIPSI test, which is also called as 2-hour OGTT. It is an Indian guideline. Okay. If the test is normal at the first antenatal visit, then you are supposed to repeat it between 24 to 28 weeks. Okay, what is the minimum gap between two tests? Minimum gap between two tests should be 4 weeks. Okay, it should be at least 4 weeks. Remember, if the patient comes beyond 24 weeks, you do the test only once. Then you will do the test only once. Okay, values which are more than or equal to 140 are taken as GDM. But if they are more than or equal to 200, we call it as overt diabetes. Okay, overt diabetes. Shabash. Okay, quickly, I want to know from you, is this also clearing all the confusions that you had? Sometimes you have a lot of confusions. Ye sahi hai ya wo sahi hai. So is it also clearing the confusions that you probably had? Yes or no? That is my purpose, to not leave you confused at all. Okay. Yes, fasting is not mandatory. Okay. So now pregnancy loss before 20 weeks. But, conceptus weighing less than 500 is also another definition, which is a WHO definition. Okay. Now, most common cause of early pregnancy loss. Please remember, when you say early pregnancy loss, it means first trimester. Okay, it automatically means that. So answer is chromosomal anomalies. Cervical insufficiency will present as second trimester. Recurrent pregnancy losses, they should be more than or equal to 3, and they have to be painless. Okay, and they have to be painless. Okay. Trisomies in general are the most common cause in early pregnancy. But if we ask you single most common, then what is the answer? Then the answer is monosomy X followed by trisomy 16. So this is if you have to answer not as a group but individual. Okay, if we ask you most common cause of RPL in the first trimester, then it is chromosomal. If we ask you in the second trimester, uterine abnormalities. Please remember, in uterine abnormalities, cervical incompetence is more common than septate uterus. Okay, right? So please remember this. Also, please remember, Mullerian anomalies will generally cause which trimester losses? Second trimester. So generally they will cause second trimester losses. Okay. APLA is also an important cause, but it's not a group. So groups are more common. APLA is the single most common cause. Okay. So please understand the difference. Here we are talking about a group. Uterine abnormalities is a group. Okay. APLA is the single most common cause. आ तो रहा है, धीरे धीरे करके सब आएगा. So single most common cause of RPL. Okay. Especially when you talk in the second trimester. So APLA. एंडोक्रिनोपैथी कभी एग्जाम में ऑप्शन नहीं होता, अलग अलग ऑप्शन होते हैं. दे से थायराइड, डायबिटीज, पीसीओएस. इसलिए आई डोंट वांट यू टू बी कंफ्यूज्ड. Endocrinopathy as a group is never in the options. It is available as individual entities. That is why if the option is uterine abnormality and thyroid dysfunction, what will you mark? Uterine abnormality. Okay? Chalo. So please remember, the patient can have vascular thrombosis, but she can also have pregnancy morbidity. It can be one or more loss at more than 10 weeks or more than or equal to 3 losses at less than 10 weeks. Okay? At least one preterm delivery due to what? Severe preeclampsia or uteroplacental insufficiency, which means you have to know the reason for preterm. If the reason for preterm is polyhydramnios, it's not APLA. The reason have to be severe preeclampsia or UPI. Okay, bacha? Chalo. Lab criteria. Please remember they have to be positive on 2 occasions 12 weeks apart. What are the lab criteria? So they are lupus anticoagulant and anticardiolipin antibodies. Now remember, to look for lupus anticoagulant, we do the Russell Viper venom test, or we can do APTT, right? Whereas for anticardiolipin and anti-beta-2-GP1, we are going to do IgM and IgG antibodies in medium to high titer. Now, what criteria have you written here, right? These criteria, clinical plus lab, right? So, we need one clinical criteria and one lab criteria to finally say my patient is diagnosed as APLA. And this is what is called as Sydney or Sapporo criteria. Okay, Sydney or Sapporo criteria. Now, listen to me very carefully. If the treatment of APLA is asked and no other details are given, then the general answer will always be a combination. Okay, the general answer is always going to be a combination. Okay, is that clear? Is that clear? Now, please remember, if you have to know, if they give you more details, like the patient has abortions or the patient has thrombosis, only then you will add low molecular weight heparin. If in the exam they have given you that the clinical criteria is preterm labor, then and no abortions, no thrombosis, then you will give only aspirin. Is that clear? Give me a thumbs up if it is clear to you. So if it's only preterm labor, no thrombosis history and no abortion, then you will give the patient only aspirin. Is this clear? Right? I'm writing down everything so that you don't have to go and see anything else, bacha. Okay? So if the clinical MCQ says patient has had abortions or the patient has had thrombosis, then you have to give both the drugs in the next pregnancy or current pregnancy. Right? If the question says that she has only history of preterm labor, then you will give only aspirin. You're not going to add heparin. Okay? Okay, let's go forward now. Please remember, for cervical insufficiency, it has to be more than or equal to 3 losses, but very, very importantly, the key word is painless losses, and they have to be in the second trimester. Okay? Yes, the drugs for APLA are given throughout pregnancy. Okay? Throughout pregnancy. What is the most common type of cerclage? It is going to be McDonald's. What is the ideal time? 12 to 14 weeks. Single best answer, 14 weeks. Right? Please remember the contraindications. The most important one is ruptured membranes. Apart from that, current pelvic infection and presence of gross congenital anomaly are going to be absolute contraindications, right? Please can you tell me the surgeries that can be done in pregnancy? So they are McDonald's, okay? Then it can be Shirodkar. It can also be a worm stitch or a worm cerclage. Which ones do you do in the non-pregnant? Which ones are you going to do in the non-pregnant? Right? The non-pregnant can be lash and lash. It can be Benson and Durfee. It can be laparoscopy. But which is going to be the treatment of choice in non-pregnant? In non-pregnant, the treatment of choice will be laparoscopy. Okay? Right? Is that clear? Okay. Yes. Cervical length less than, I think everybody knows, the cutoff is 25 mm or 2.5 centimeters. ठीक है बच्चा? चलो आगे बढ़े. Okay. Now, please remember, when do you remove the stitch? So remove the stitch at 37 weeks or whenever she goes into labor or she develops ruptured membranes, right? So you will have to remove the stitch. Okay, let's go this. Clinical entities are important. What is the answer for the first one? Os closed, cardiac activity absent. This is going to be a missed abortion, right? Okay. Internal os is closed, cardiac activity present. This is going to be a threatened abortion. Os closed, all POCs expelled. This is going to be a complete abortion. Os is open, no POCs have been expelled out. Then this is going to be inevitable. Os open and some POCs have been expelled, or they can write POCs in cervical canal. Then it is going to be, yes, incomplete. Now quickly remember, in missed abortion, uterine size is less than POG. Threatened में, uterine size is same as POG. Complete में, uterine size less. Inevitable, uterine size corresponds. Incomplete, uterine size less. But they should not be the primary things that you look for. इसलिए मैंने बाद में लिखा है. The primary things are the ones that I've written first. You make the diagnosis on the basis of that. Okay, good to go everyone? Chalo. Let's do this. MTP, very important. Dose of mifepristone, remember it is called as RU486, is going to be 200 milligrams and the route is oral B2. After 48 hours, the dose of misoprostol is going to be 800 micrograms. Now, please remember, there is no division, okay, of up to 7 weeks and 7 to 9 weeks. The latest guidelines have removed the division and they are giving a single dose up to 9 weeks. So MTP, which is called as MMA, medical methods of abortion, they will be allowed up to 9 weeks. That is what you're supposed to answer. Okay. 800 micrograms can be given buccal, oral, sublingual and even vaginal. Okay. So, suction evacuation, please remember, is a method of first trimester abortion. So, this is done up to 12 weeks. What size Carmen's cannula are you going to use? The size should correspond to the uterine size or POG. Okay. What about MVA? It is done up to, again, 12 weeks. But MVA will use a 60 cc MVA syringe. Okay. And it does not use, there is no electric current. Electric current is required for suction and evacuation. Okay. Yes, up to 9 weeks, OPD base. That's right. Okay. Please remember, the MVA and suction evacuation are the surgical methods. Okay. older surgical method not used now in the first trimester was D and C. Now it is not used. Now we are using either suction evacuation or we are using what? MVA. But older times we were using also D and C. MVA is manual vacuum aspiration. Okay, so manual vacuum aspiration. Okay, is that clear? Please remember the pressure for both, whether they say, you know, suction evacuation or MVA, is generally 600 millimeters of mercury. In case they go more specific and option is available, then 660 is a better answer for MVA as compared to 600. Okay? So 660 is a better answer if available. If not, 600 is the general answer for the pressure. Okay? MTP in second trimester, again very, very important. If they ask you can be done up to, you have to answer it as 24 weeks. Consent kiska chahiye? Only the patient. Husband consent is not mandatory. Yes? Okay. Up to 20 weeks, opinion of one registered medical practitioner is required, right? And between 20 to 24 weeks, we need consent of 2 registered medical practitioners. For GCA, GCA is the only condition for which you can do MTP even beyond 24 weeks. Right? So beyond 24 weeks, only for one condition it is GCA. But we will need approval of medical board. And remember, medical board has an obstetrician, it has a radiologist, and it has a pediatrician. So you can remember it as the Sethi family, right? Dr. Sumit, Dr. Siddharth Sethi and me. Right? So remember the Sethi family forming the medical board. Okay. Gross congenital anomaly. Anushka, Amisha, gross congenital anomaly beta. Okay. If we ask you most commonly used method in the first trimester, second trimester, we are talking about second trimester, then it is going to be prostaglandins. And in the prostaglandins, it will be PGE1, which corresponds to myso. Okay, myso. What is the dose? The dose in the second trimester for myso is 400 micrograms. We put it every 3 to 4 hourly for a maximum of 5 doses. Okay, so we usually put it per vaginally and for a maximum of 5 doses. Okay. What are the other drugs? So, extra amniotic, ethacridine. Yes, the video will also be uploaded, but I want you to do it live, Vishal. Sare bache, you're going to promise me you're going to do it live. Is it a promise? Yes, because when you do it live with me, it's a hell lot of difference. I will hammer it into your head and you will not do it wrong. You will hear my voices. I will haunt you in the NEET PG exam, right? So do you all want your faculty to haunt you in the NEET PG? Yes or no? Give me a big yes. Yes. Yes, you want the faculty to haunt you. You want to hear our voices as well, right? Okay. Yes, can we use other prostaglandins? Yes. The other prostaglandins are PGE2 and even PGF2 alpha. Okay, so they can also be used in the second trimester. Now, which is the surgical method in the second trimester? It is called as D and E, not D and C. Alag-alag hote hain. What device do you use here? You use a ovum forceps. Okay, you use a ovum forceps. Okay. Okay, now let's go forward. We move on to the next important topic of the day, and that is going to be ectopic pregnancy. Chalo, risk factors. So previous ectopic is what carries highest risk. Even tubal reconstructive surgery like tubal ligation also carries a highest risk. But when we ask you most common, okay, DNC अब नहीं करते बच्चे, DNC अब non-pregnant में करते हैं, right? Earlier we were using D and C, okay, for first trimester abortions. Now we are not using, okay. So D and C, if at all it comes, remember first trimester, okay. Then most common cause अगर पूछेंगे and they are PYQs, then it is PID, okay. कोई बात नहीं आशीष, बुकलेट जल्दी मिल जाएगी, मैं देने आती हूँ. I'll run and come to you, okay. Now the other important risk factors, please remember, among the contraceptive methods, which methods are going to increase the risk? They are, yes, the biggest one is tubal ligation, okay. The next high risk is with intrauterine device, and then it is with progesterone only pills. In intrauterine device, remember what is more high risk? It is Mirena. Mirena में risk ज़्यादा है as compared to copper T. Shabash. What else? Please remember, even a previous cesarean scar, right? So if there is a scar tissue, that is also a risk factor. Is that clear? Risk factors for ectopic have been coming as PYQs, single liners, even as applied MCQs. Okay. Progesterone only pill. POP is POP, progesterone only pill. Okay. What is the obstetric triad? So if an MCQ comes, your patient is in early pregnancy and she comes with pain, amenorrhea and bleeding. What is the single most important one out of this? Yes, pain is the most common symptom. So lower abdominal pain, right? So then you have to think of ectopic. Now, in case you see remember, extrauterine gestational sac with cardiac activity or embryo, then this is diagnostic of ectopic. Okay, so this is diagnostic of ectopic. But in case you see a complex mass, okay, if you see a complex mass and you see ring of fire sign, yes, or you see tubal ring sign, also called as bagel sign, then you will have to follow it up with HCG, right? So if you are not seeing an extrauterine sac, what you are seeing is a complex mass, and complex mass में हमने ring of fire भी लिख दिया. Then we ask you, what do you do next? You have to answer it as HCG and you have to look at discriminatory score. The score for abdominal ultrasound is 6500. What is the score for vaginal ultrasound? 2000 international units. Okay. Now, in case the value of HCG comes less than the discriminatory score, then what do you do? So, if the HCG value is less than 2000 and no intrauterine pregnancy is seen, then you will answer it as repeat HCG after 48 hours. It's a NEET PG PYQ. Then you have to answer it as repeat HCG after 48 hours. Okay. Very, very important beta ji. Next topic, management. सारे कान के उल्के सुनेंगे और कभी गलती नहीं करेंगे. Okay. Clear? Good to go. Let's do this. Medical management is in general our preferred management for ectopic. But to do medical management, the criteria have to be met. These are the keywords. The patient has to be stable. It has to be unruptured ectopic. Okay. Sac size should be less than 4 centimeters. HCG should be less than 5000 international units. And cardiac activity has to be absent. Okay. Drug of choice is methotrexate, 1 milligram per kg or 50 milligram per meter square given as an IM injection. It is a single dose regime. Okay, it is a single dose regime. Is that clear? After giving this, you will do HCG values on day 4 and day 7, right? And day 7 value has to fall. Okay, please remember. Okay, so don't do this mistake. If it is successful medical management, as I said, day 7 value has to fall by at least 15%. Okay, now very, very important. If we are talking about unruptured ampullary tubal pregnancy, and in case you are doing a surgical procedure, when would you do surgical? Just reverse of this. इसको reverse कर दोगे तो surgical procedure का आंसर आ जाता है. मतलब I am going to write it here. You will do surgery if the patient is unstable. You will do surgery if it is ruptured. You will do surgery if it is bigger than 4 centimeters. If this is more than 5,000, anytime cardiac activity is present, the preferred treatment has to be surgical. Is that clear? Never mark medical if cardiac activity present. Okay, is that clear? Now, what surgical management are you going to do? If the ectopic is unruptured, then it has to be a salpingostomy. Okay, it has to be salpingostomy. If they will confuse you, they will ask you about salpingectomy. You will do this when these words are written. Ruptured ectopic, sac bigger than 5 centimeters, or if they have written the patient is hemodynamically unstable, right? Or family is complete, right? So family complete, ruptured ectopic, never mark ostomy. Is that clear? Are you with me? Give me a thumbs up. So yes, ruptured ectopic, bigger than 5 centimeters. Yes, unstable. Okay, family complete jectomy. Cardiac activity agar present likha hai, the answer will be surgical. So if these words are used, okay, so if these words are used, then the answer will be surgical. Okay, be very, very careful. Okay, chalo aage badhe. Named criteria already given to you. Cervical is Palman. Older criteria were Rubin. Okay, older criteria were Rubin. Ovarian के लिए Spiegelberg. Abdominal के लिए Studiford. Okay, the criteria I have given to you here, please read them once, especially the Spiegelberg criteria. They are important for your NEET PG exam. Just go through them at least once. Okay. Now, antepartum hemorrhage, NEET PG, very important. Abruption, keywords. What are the keywords, Rajay? Let's do this. Are you with me? Yes. Bleeding. And the bleeding is associated with pain. But most common symptom is bleeding. It is altered in color, dark in color, right? So, altered in color, dark in color. Okay, is that clear? Then, please remember, the uterus will be tense. The uterus will be tender. The fundal height will be more. And because it is a tense uterus, fetal parts easily felt or difficult to feel? Difficult. Okay? Okay? Difficult. बेटा अपडेट नहीं है, आपको पागल बनाते रहते हैं अपडेट दे दे के. Please understand the cutoff is 4. Obviously, the smaller the size of the sac, the better it is. So, if it is 3, 3.5, it is perfect. But up to 4, as I said, more than or equal to 4 centimeters should be surgical management. Alright? Risk factors, super important. So, remember pre-eclampsia, previous history of abruption, then trauma, then polyhydramnios, very important. Then please remember smoking, increased age, increasing parity, they are important risk factors. Okay, premature rupture of membranes and even fibroid uterus, they are risk factors for abruption. Important. Please remember the name of the classification is PAIDS classification. Okay, PAIDS classification. Then मैनेजमेंट, जिस पे आप सब कंफ्यूज होते हो, और अगर आपने डीबीटी करा होता तो आपको रियलाइज होगा, एज आई सेड, नीट पीजी क्या INI-CT के क्वेश्चंस भी यहीं से हैं. ओके, सो प्लीज रिमेंबर, इमरजेंसी सिजेरियन सिर्फ तभी करना है इफ द मदर इज अनस्टेबल और देयर इज फीटल डिस्ट्रेस. ओके, प्लीज रिमेंबर, वेजाइनल डिलीवरी कब करना है? इफ the mother is stable or fetal heart rate is normal, or even if it is mentioned as IUD. Once there is an IUD, the preferred mode should be vaginal delivery. Only one exception. If there is IUD and DIC and she is far from term, matlab she is not in labor, she is far from term, let's say IUD hai, DIC hai, she is 32 weeks, then yes, it is an urgency. Then in this IUD you will do a cesarean. Otherwise, stable heart, stable mother, IUD, it's all vaginal delivery. Even IUD with DIC is vaginal, only if they say far from term, not in labor. Those are the keywords. Only in that case the answer will change to CS. Is this clear? Good to go. Concepts gadbad nahi karo. I always give concepts in class as well. Is that clear? Okay. Please remember, conservative management zyadatar nahi karte. So in general, when we ask you treatment of choice, okay, so when we ask you treatment of choice for abruption, in general, the answer should always be delivery. Okay? Okay, the treatment will always be delivery in general for abruption. Very rarely you will do conservative management. That is done only if mother and baby are stable and she is remote from term, matlab less than 34 weeks, with no DIC, no contractions. Otherwise, always and always, the general answer for abruption is delivery. Is that clear? And because the treatment of choice is delivery, there is no role of tocolytics in abruption in general. Okay? So please understand this. Alright? Now, as I said, in severe abruption, there is DIC, which is because of release of what? Tissue thromboplastin. अरे भाई, अगर वेजाइनल डिलीवरी करना है, then one of the ways to accelerate delivery is ARM na baba. So in abruption, you want to do a quick delivery, and one of the ways to accelerate the process is rupture of membranes. It will cause release of prostaglandin. So we will always do that. Yes? Now, please remember, when we talk about cuvillaire uterus, Dr. Anil will show you the picture as well. So cuvillaire uterus is also called as uteroplacental apoplexy. Okay, uteroplacental apoplexy. Okay, so it is a discolored uterus because of blood in myometrium. Remember, cuvillaire uterus is not a indication for hysterectomy. That's important. But is it a risk factor for PPH? Yes, it is a risk factor for PPH. Yes, yes, yes. IUD with DIC, if she is already in labor, yes, definitely the preferred mode will be vaginal. You do a cesarean only when there is DIC and early vaginal delivery is not possible. So that is why I said keyword is far from term. Only then you change the answer to what? Cesarean section. Is that clear, everyone? Chalo. Okay, let's move on to placenta previa. What are the keywords? This bleeding is going to be bright red or fresh bleeding. It has to be painless. It has to be causeless. And with this bleeding, what is going to happen? There are episodes of small bleeding, which is called as warning hemorrhage. Warning hemorrhage is used classically with placenta previa, right? And fundal height will correspond to POG most of the times. It is a relaxed uterus. It is going to be non-tense and non-tender. But yes, sometimes in placenta previa, fundal height may be less. When do you think the fundal height will be less? This is typically seen when there is transverse lie. Why? Because placenta previa has a very strong association with transverse lie. Okay? So that is why it sometimes may be less. Quickly tell me, when do you say it is called as a low-lying placenta? Low-lying कब कहते हैं? When it is within 2 centimeters of internal os. What is the investigation of choice for placenta previa? It is transvaginal ultrasound, right? So investigation of choice for abnormally located placenta or placenta previa will remain as transvaginal ultrasound. Risk factors. So multiparity and increasing age and smoking, very important, have been pre-IQs. Previous placenta previa, the most important risk factor, previous cesarean section. More the number of cesarean sections, the higher is the risk. Mullerian anomalies, any kind of scar in the uterus. It could be a scar of curettage. Okay. So these are very, very important risk factors. Okay, one risk factor that I forgot and is very important is multifetal pregnancy. Age was written here, right? Multifetal pregnancy. Suresh, don't worry about the types. As I said, Dr. Anil will cover the images separately. We have a separate section of OBGY images. See, the purpose is we don't want you to look at anything else. So we'll cover theory also, we'll cover images also. Fundal height will be less when it is associated with transverse lie. Placenta previa has a strong association. Okay? कोई बात नहीं, AN जहां से ज्वाइन करो वहीं से सवेरा. जब ज्वाइन कर लो तभी सवेरा, तभी से enlightenment शुरू. So start doing it from this topic. Okay? Okay. Now, please remember, whenever the MCQ says, right, there is a fetal distress or there is maternal unstable vitals, the answer has to be emergency cesarean. Okay. Otherwise, we can do a conservative management, okay, which is referred to as Johnson's and McAfee's regime. Okay, so Johnson's and McAfee's regime, where you are going to monitor the mother and the baby. Apart from that, you will send all baseline investigations. You can give steroids if the POG is less, and we can even give tocolytics if she is in labor, right? So tocolytics if there are uterine contractions and the patient is less than 34 weeks, right? So then yes, we can give tocolytics as well. But please remember, there is no role of cerclage. Yes, the tocolytic we will do in preterm labor, but the drug of choice is nifedipine, right? So nifedipine is what we use. There is no role of cerclage, okay? Term हमेशा 37 weeks and beyond माना जाता है, okay? Please remember that. No blank is left. I think I filled up all the blanks. Kacha Pati. Please remember, no PSPV in placenta previa. But can you do PSPV in abruption? Yeah, yes. So please remember, if a patient of APH comes, you have ruled out placenta previa, you can do what? PS and PV. Once you rule out placenta previa, you can do PSPV. Okay? Chalo. Complications. If placenta previa occurs over previous scar tissue, then what is going to happen? Okay? Then it will result in PAS. What is PAS? Placenta accreta spectrum. Okay? Placenta accreta spectrum. Okay? Now please remember, right? When we talk about PAS, it has absent decidua and it has also absent Neta-Bux membrane, right? So absent Neta-Bux membrane, absent decidua. Investigation of choice, ultrasound. You may combine it with Doppler, but the most IOC is going to be ultrasound, right? Also, please remember, MRI will be done only when diagnosis is uncertain or we want to know about depth of invasion. Then we will do MRI. MRI is not done for all patients. It is not required. What is the classic finding of the, placenta? We call it as heterogeneous placenta. Okay. We call it as moth-eaten placenta. And we say there are going to be intraplacental lakes. So remember these words, moth-eaten, heterogeneous, intraplacental lakes. Is that clear? Yes, transvaginal is done. There is no problem. Okay. Vasa previa. Okay. Vasa, best, yes, MRI. As I said, when in doubt, you can do an MRI. So MRI is definitely better, but we don't need it in all the patients. Is that clear, bacha? Okay. PSPV, is per speculum per vaginal examination. Okay, vasa previa. This is when the fetal blood vessels cross over what? They cross over the internal os. It is also a cause of antepartum hemorrhage. But what is special here? This is, as I have highlighted, this is fetal blood. Okay, it is fetal blood. Okay, now please remember, this has a strongest association with velamentous cord insertion, but it can also be associated with what type of placenta? Yes, placenta succenturiata. But the single best answer will be velamentous. Okay, now please remember, since it is fetal blood, what test can you do? So bleeding is fetal here. Okay, what test can you do? APT. APT is alkali denaturation test. Yes, APT is alkali denaturation. We use 1% NaOH. Okay, we use 1% NaOH. And this bleeding will be associated with severe fetal distress. That is why the treatment of choice for vasa previa is emergency CS. Okay, emergency cesarean section. What is the management of PAS? Can you tell me? Treatment of choice for PAS is a cesarean hysterectomy. And the cesarean that we typically do here will be classical cesarean. So we are going to do a classical cesarean and hysterectomy for PAS, and we will do an emergency cesarean for vasa previa. Okay, uterine rupture can also cause antepartum hemorrhage. But what would be the keywords when it comes to uterine rupture? What will be the keywords? Okay, the patient will have pain, but this will be a generalized abdominal pain and it may be associated with maternal hypotension. Please remember, in abruption, the blood pressure tends to be high. Okay, the blood pressure tends to be high. But with rupture uterus, there will be hypotension. So there will be pain. But please remember, बहुत सारी चीजों का loss होगा. What? Loss of uterine contractions. They will stop. और क्या होगा? Loss of uterine contour. You cannot feel the uterus easily. What else? Fetal parts become superficially palpable. In abruption, fetal parts are difficult to feel because the tone is high, right? And what is going to happen to the most specific sign? Yes, that is loss of station. Loss of station is not seen with anything else. Okay, please remember, if we ask you most common sign of uterine rupture, it is defined as non-reassuring fetal heart rate, which is a fancy way to write what? Yes, fetal distress. Okay. What are the risk factors? You all know. Previous cesarean. More the number of cesareans, the higher is the risk. किसमें risk ज़्यादा होता है? Classical में या LSCS में? So risk of rupture is much more in classical than in LSCS. Okay. Now, the other important risk factor, obstructed labor. So in non-scarred uterus, the most common cause is obstructed labor. Among drugs, the most important one is misoprostol. Absolutely contraindicated for induction of labor in previous cesarean. We will never give it. But remember, oxytocin can also cause rupture. But which drug will be the single best answer? Misoprostol. Yes. Grand multi-para, more than or equal to 5, can also be an important risk factor. Good to go. We come on to the very important fetal parts, superficially palpable bacha in, uterine rupture, difficult to feel in abruption. See, this is why we wanted to do a special session for all of you on the app. We are doing it twice. Do you realize? I'm going to say all the things all over again in the Shri Fort auditorium, but we wanted to give all our dear bachas on the app equal attention, and that's why each faculty is going to do their session twice just for you, so that we can see your chat, we can respond, and we can help you with your doubts. Okay? Chalo. Please remember, GTD includes molar pregnancy and GTN. मगर जब आप GTN बोलते हो, it includes invasive mole. The next common one is choriocarcinoma. Then comes PSTT and then comes ETT. Okay? Then comes ETT. So most common among GTN is invasive mole. Okay? Very, very important. Complete mole 46XX. They are diploid. Okay. They are monospermic. Okay. They are diploid. They are monospermic. Right. What is the appearance of the uterus? You all know snowstorm. But do you know Swiss cheese? Yes. Please remember, it's also called as Swiss cheese. It's also called as honeycombing. Right? But yes, no doubt the most popular one is which one? Yes, it is snowstorm. ETT is epithelioid trophoblastic tumor, placental site trophoblastic tumor. Okay. Now, what will the adnexa show? They will show bilateral ovarian cyst. What is the name? We call it as honeycomb. Sorry, the name is theca lutein. Yes. So, theca lutein cyst. Okay. PSTT is placental site trophoblastic tumor and epithelioid trophoblastic tumor. All right. Partial moles are triploid 69XXY. They are dispermic. Okay, they are dispermic. There is no theca lutein cyst here. There is no snowstorm appearance here. What is a big no in complete moles? There is no fetus, while fetus is present here, right? This will show focal hydropic change of the placenta, whereas complete mole will show what? All over hydropic change. बच्चे गड़बड़ नहीं करना. HCG is high in both, but it is much more high in complete mole. Okay, HCG is high in both partial mole and complete mole, but the value in complete mole is much more than partial mole. Yes, P57 rare चीज है, आज तक कभी MCQ में नहीं आई, but yes, partial mole is P57 stain positive, complete mole is negative stain. Okay, चलो आगे बढ़े. ये टेबल आपके लिए है, एक बार गो थ्रू कर लीजिए. इट इज एन इंपॉर्टेंट टेबल फ्रॉम विलियम्स ऑब्स्टेट्रिक्स. जस्ट गो थ्रू दिस. यस, the baby will eventually die beta because it is triploid, and you have to know triploid is not compatible with life. So the baby is going to die. It has multiple anomalies. Okay, that is why partial moles are misdiagnosed. The report often comes as missed abortion. Okay, so sweet of you, Anjali. Thank you so much to remind me to have water. Super important. That's my source of energy for today. Okay, what is the treatment of choice for molar pregnancy? Suction and evacuation. What is the period of surveillance for complete mole? 6 months. What is the contraception of choice? Combined oral contraceptive pills. Which one is to be avoided? Intrauterine device. Okay. If you have done suction and evacuation and the patient's age is more, HCG is more, there are large theca lutein cysts, okay, the cutoff is more than or equal to 6 centimeters, and fundal height is also more, then these patients will be given prophylactic chemo. The drugs that we use for chemo are methotrexate and actinomycin D. Please remember, because we are not giving chemo to all, it is called as selective patients. Okay, now if 3 consecutive HCG values, because when we say we are going to do a follow-up, we do weekly follow-up. So if 3 consecutive values show a rise over 2 weeks, तो मेरी बात ध्यान से सुनो. वैल्यूज 3 हैं मगर वीक्स 2 हैं, एक कम होते हैं. या फिर there are 4 consecutive values which show a plateau over 3 weeks. So values 4 हैं मगर weeks 3 हैं. या फिर if there is a histopathological evidence, then these are criterias for what? Saying that your patient has GTN. Okay, now choriocarcinoma most commonly arises after complete mole. Please don't answer vaginal delivery. Vaginal delivery के बाद it is uncommon to have GTN. But yes, if it happens, okay, so vaginal delivery, it is uncommon to have GTN. But if it does, then chorio will be more than PSTT. ठीक है? Now, most common site of metastasis, lungs, 80%, followed by vagina, 30%. Who is going to tell me the appearance in the lungs? Yes, cannonball. Who is going to tell me the appearance in the vagina? Yes, blue suburethral nodule. Okay, suburethral nodule. Okay, PSTT is a very rare tumor. It is a rare tumor. Epithelioid is even more rare. But if it happens, they will follow a normal vaginal delivery. Okay. Hanji, management. बार बार नीट पीजी पूछता है, so be careful. Now please remember, if your patient is stage 1 GTN or if your patient has a WHO score of less than or equal to 6, okay, then we will use single drug, okay, volume. We will use single drug but multi-dose regime. Okay, मतलब बार बार देना है, right? So day 1, day 3, day 5, day 7. And what do you give on 2, 4, 6, 8? What do you give? Folinic acid. So this is what is a multi-dose regime, right? It is single drug but multi-dose. Drug of choice is methotrexate. If there is resistance, then actinomycin D. Okay? High risk. Patients who are stage 4 GTN are anyways called as high risk. Or if they have a WHO score of more than or equal to 7. Right? Then, which therapy will you give? Multi-agent chemotherapy. And what is the name of the regime? Imaco. You have to know the name of the drugs. So, etoposide, methotrexate, actinomycin D, cyclophosphamide, and oncovin. Follow-up, whether it is low risk or high risk, the follow-up is 12 months. And please remember, the contraception of choice remains as OCPs. Okay. Please remember, lungs is considered as stage 3 GTN, but still it is considered as low risk or good prognosis. Metastasis to vagina is considered as stage 2 GTN and again generally considered as good prognosis. मैंने बोला बेटा कि vaginal delivery के बाद GTN नहीं होता. It is very very uncommon. अगर गलती से हो गया, if it happens after vaginal delivery, which is a rare event to happen, then the more commoner one is choriocarcinoma after vaginal delivery and even more rare is PSTT. So most cases of choriocarcinoma that you see, okay, so most cases of choriocarcinoma that you see are coming after complete mole. Is that clear? Okay. Let's go forward. Are you ready, everyone? Okay, we move on to the next topic and that is going to be preeclampsia. So BP more than 140 by 90, 2 occasions. What else do we need? We need proteinuria and or end organ damage. Please remember, for proteinuria, dipstick criteria is more than or equal to +2. 24-hour urine protein criteria is more than or equal to 0.3 grams. Protein creatinine ratio is again more than or equal to 0.3. In case your patient has hypertension but no proteinuria and no end organ damage, then how do you classify? Gestational hypertension. Yes. So then you will classify her as, अरे भाई बोल तो मैं रही हूं और ब्रेक तुम लोगों को चाहिए. हाँ चलो. It has to be quick. It has to be rapid. It has to be good recalls so that we make most use of these sessions. Believe me, once you do it with me, you will do it even faster alone. It will be like a quick go through, an entire obs and gynae is done. Chalo. What is considered as end organ damage or what is considered as severe preeclampsia? Okay. So liver enzymes more than twice. Platelet count less than 1 lakh. Pulmonary edema, blood pressure more than 160 by 110. Okay, so it can be either systolic or diastolic or both. ठीक? Headache, dizziness or visual disturbances. So if any of this is present, then your patient has preeclampsia with severe features, right? And these are also what are considered as end organ damage. Okay. Now, drug of choice for hypertension, labetalol. Remember, it is a alpha plus beta blocker. Quickly, what drugs are contraindicated? Yes. So, ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics, and even diazoxide. In the order of importance I have written, right? So they are all contraindicated in pregnancy. Okay? Now, if your patient has preeclampsia and there are no severe features, blood pressure is controlled, you do a termination at 37 weeks. Okay? Then, if there are severe features, controlled blood pressure, then you will do termination at 34 weeks. Now, impending eclampsia is very, very important. Anytime your MCQ writes words like headache, vomiting, and epigastric pain, you have to take it as IE. Okay? And when they ask you next step, the single best answer is going to be Magsulf. If you can answer multiple answers, then it has to be Magsulf with labetalol, which will be given IV. And once you stabilize the patient, you will do a termination of pregnancy. So you first stabilize and then you terminate. Preferred mode of delivery is vaginal. Please remember the preferred anesthesia is neuraxial. Neuraxial का मतलब है we can give both spinal as well as epidural. Both are safe. Both can be given, right? But in case they write the platelet count is low, then which one will you give? So if they write low platelet count, then you should give preference to spinal, right? So then you should give preference to spinal, okay? Now, what is the cause of seizures in eclampsia? So eclampsia is preeclampsia with seizures, okay? Now, please remember cause of seizures is cerebral edema as well as cerebral hypoxia, okay? What is the first step? You have to stabilize the position of the patient, okay? Then you will do an airway maintenance. How? By putting a mouth gag. Once you have maintained the airway, then you will give Magsulf. And after Magsulf, you have to also take care of labetalol. And once you do that, you're going to do termination of pregnancy. No conservative management in eclampsia. Please remember the preferred mode is again going to be vaginal delivery. Okay, the preferred mode will be vaginal. Let's quickly do this. Magsulf, super important drug, right? What are the therapeutic blood levels? 4 to 7 milliequivalents. Okay, loading dose is 4 grams IV. It is a 20% solution. And along with that, we have to give 10 grams IM. The 10 grams is a 50% solution. Please remember, loading dose has to be given irrespective of kidney function. There is no checking of kidney function before loading dose. It acts on NMDA receptors in the brain. But if we ask you in the periphery, it will act on the calcium channels. But in the brain, it is NMDA. First sign of toxicity is loss of patellar reflex. Please remember, oliguria is not a sign of toxicity. Okay, so oliguria is not a sign of toxicity. Antidote, 10 ml of 10% IV calcium gluconate. Okay, so 10 ml of 10% IV calcium gluconate. What are the other two important uses of Magsulf? Tocolytic. It is used as a tocolytic and it is used for neuroprotection of the baby when the POG is less than 32 weeks. Okay, neuroprotection. We'll talk more about it. HELP syndrome. Remember the name of the criteria? Tennis criteria. There has to be hemolysis, which means indirect bilirubin is raised. Okay, and the peripheral smear will show schistocytes. I'm sure you know it is also called as helmet cells. The LDH levels will be low but high, and haptoglobin levels will be low. Okay. Apart from this, there has to be elevated liver enzymes more than twice. Platelet count has to be less than 1 lakh. If all three criteria are met, then you say it is HELP syndrome. Termination of pregnancy in HELP is done at and beyond 34 weeks. So once she is 34, it is severe preeclampsia, you deliver. Okay. Acute fatty liver. Prevalence is 1 in 20,000. Has been a NEET PG, one of the options in the PYQs. Okay. Maternity mortality rate is very, very high. Alright. Now, which enzyme deficiency? Remember, it is LCHAD, but this deficiency has to be in the fetus. The other important risk factors are primigravida, multifetal pregnancy, preeclampsia, and male sex of the baby. Okay. Remember, it presents in the 3rd trimester. Symptom. The patient is going to come with pain, epigastrium, and I am writing signs of liver failure. That's the most important thing. This is what will differentiate it from HELP. So which means in the MCQ, they will give you these things. Low glucose, right? High ammonia. They may give you altered consciousness or altered sensorium, which means encephalopathy. Rising creatinine, which means hepatorenal syndrome, and then the patient can develop complications like pancreatitis as well as DIC. These things are not present in HELP syndrome. Management, termination of pregnancy irrespective of POG, right? It has a high mortality rate. Okay. Intrahepatic cholestasis. It is primarily stimulated by estrogen, right? And it is seen in women in the 3rd trimester. But please remember the other important risk factors. Multifetal pregnancy, female sex. Okay, so multifetal pregnancy and female sex. Okay, they are important risk factors. The gene that I want you to remember is ABCB4 mutation. Okay, ABCB4 mutation. What is the most specific sign or symptom? This is going to be pruritus. Please remember, there is no pain. In HELP syndrome and in AFLP, there is pain. Labs will show mild elevation of bilirubin, but it's not diagnostic. What is the diagnostic finding? Yes, the diagnostic finding is raised serum bile acids. Okay, that's what is diagnostic. Now, please remember, when it comes to intrahepatic cholestasis, it only causes pruritus in the mother, right? But when we talk about the baby, it can cause sudden death. It can cause meconium aspiration syndrome, and it can cause prematurity. The reason for all these complications is bile acids. The reason for sudden death is cardiac arrhythmias in the baby, right? And that can cause sudden death. What is the management? Okay, so please remember, we are going to give her ursodeoxycholic acid. That is the drug of choice. And induction of labor can be done at 37 to 38 weeks, not preterm. Do not do a preterm delivery. 37 to 38 weeks. So any time beyond 37 weeks. Is that clear to everyone? Okay. Now some of these smaller topics, so only very specific things which have the highest probability of being asked. Harshit, mass is meconium aspiration syndrome. Okay. Now, quickly talking about things that we should know about heart disease. Now, you will switch over from warfarin to low molecular weight heparin in the first trimester. But when do you do this switch over as per the new guidelines? Only if the dose is more than 5 milligrams per day, right? So only if the dose is more than 5, then you do a switch over. If the dose is less, we can continue warfarin, okay? If nothing is mentioned about the dose, then you can simply answer switch over. I am repeating. If the dose is not mentioned, then the question is very simple. You just have to say switch over, okay? When do you switch over again? So again, you will switch over to warfarin at 12 weeks. They are all PYQs. Switch over again, the third switch over. Now this time from warfarin to low molecular weight heparin at 36 weeks. They are all PYQs. Okay. Now, what is the preferred analgesia or anesthesia? The answer is epidural. Preferred mode, vaginal. Which drug will you not give for PPH management? It is, yes, it is methergin. Because it causes severe preeclampsia. Now, if a woman is on warfarin and she goes into labor, right, you couldn't do a switch over, then this is an indication to do a cesarean section. Not just cesarean, this is also an indication to give GA. Apart from this, any time there is an emergency, then again the answer changes to GA. For example, aortic dissection. So even in that case, we will give GA. For example, the mother has refractory, listen to me carefully, refractory heart failure. Then again, it's an emergency and you will have to give GA. Otherwise, the answer remains as epidural. Okay? Okay. Peripartum cardiomyopathy, important for NEET PG. Now, patient should not have any underlying heart disease. She should not be a known case. Then if she develops heart failure, okay, and this heart failure has to happen in the last time. So, anywhere from 36 weeks to 5 months after delivery, then you will say that she has cardiomyopathy. What are the risk factors? Please remember, multiparity. Which hormone has been linked to it? Prolactin. Okay. So, prolactin. Then apart from that, preeclampsia, advanced maternal age, multifetal pregnancy are very important risk factors. Okay. Now, please remember which hormone is associated. I have already told you it is prolactin. Diagnosis is on 2D echo when the ejection fraction is less than 45%. Okay. Also, please remember, for treatment, you will treat heart failure, but we will also give dopamine agonists. Which ones? Do you remember? Yes, bromocriptine. Because prolactin is involved in it, we also add bromocriptine. Now, diabetes. Quickly, what is A1-GDM? The one which is controlled on diet. What is A2-GDM? If the patient is on insulin or on OHAs, but the drug of choice remains as insulin. Okay. Some things we have already covered, so I'm going to do this really fast. OGTT has to be done twice. We do it at the first antenatal visit, and I have told you again at 24 to 28 weeks. I said if the value is more than 140, start her on diabetic diet, which is also called as MNT. Do you know what is MNT? Medical nutrition therapy. This is a fancy name for diabetic diet. Don't get confused. So MNT-B2 is medical nutrition therapy. And if the value turns out to be more than 200, then you straight away start her on insulin 8 units. Okay. Now, patient has to keep checking her 2-hour PP value. Right? So when she is on a diabetic diet, she has to check her 2-hour PP value, right? And our target, what is our target? Batao, our target is to keep it less than 120 and the average value to be maintained at 100. Okay? So average value has to be maintained at 100. Okay? Which means if the examiner asks you the reverse, in case the 2-hour PP value after diabetic diet is more than 120, what will you do? You have to now start insulin. Okay, so now diabetic diet alone is not useful. You will start her on insulin. Yes? Okay. What? कोई बात नहीं, that is the purpose. Okay, यहाँ पे भूलो मगर मेरे साथ याद करो. And then you know that these are the most important things to be remembered, right? That's the purpose. Are you with me? How is the Josh? Come on, tell me. How is the Josh, everyone? How is the Josh? जल्दी बताओ. Hi sir, hi होना चाहिए. Okay? बेटा यूनिट्स हमेशा मिलीग्राम पर डेसिलीटर होते हैं ग्लूकोज के. ठीक है? Chalo, insulin requirements will normally increase as the course of pregnancy goes forward. So, with increasing POG. Why? Because insulin resistance also increases. Right? Please remember, in pregnancy, there is hyperinsulinemia. The reason for this hyperinsulinemia is insulin resistance. Okay? It is insulin resistance. Okay, perfect. Okay, I'm going to clap for all of you. Very good, very good. I am proud of each of my bachas. I'm going to try my best. You try yours and nobody can stop us from winning, right? Okay. Now, please remember, when we talk about anomalies, they are not seen in gestational diabetes mellitus. Which is the most specific anomaly? Ye sare PYQs hain. Okay, so what is the most specific anomaly? Yes, it is sacral agenesis. What is it called as? Caudal regression syndrome. अरे भाई, अभी भी पूछ रहे हो, is DVT enough? तुम खुद बता दो, is it enough? Yes, more than enough. Okay, more than enough. आज याद करो. Remember 50 to 70% of things with me. Okay, I'll give you a break. Don't worry. थोड़ा सा अभी करेंगे फिर दूंगी. If we ask you most common anomaly, then it is VSD. Okay, it is going to be VSD. Now, a targeted ultrasound has to be done at 18 to 22 weeks. And please remember, fetal echo will be done only in pre-gestational. The time for echo is again 18 to 22 weeks. Okay. Ultrasound can show two very important associations. One is polyhydramnios and the other is macrosomia. Okay. Now, what is the folic acid dose? It remains as 0.4 milligrams. Okay. When do you schedule induction? Schedule induction at 39 weeks if it is well controlled, irrespective of whether it is controlled on diet or controlled on insulin. उससे हमें फर्क नहीं पड़ता. If it is well controlled, 39. If poorly controlled, then anywhere between 36 to 38 plus 6. It depends on what complications patient has, how much is the urgency, right? So no one single answer for that. So that will not be asked actually. Okay. Expectant management beyond 40 weeks is not recommended. Okay. It is not recommended. Why? Because, when we talk about expectant management beyond 40, the risk of stillbirth increases, right? The preferred mode is going to be vaginal. That is why we are doing induction. CS is done if the weight is more than or equal to 4.5. But please remember, okay. Macrosomia का definition है more than or equal to 4 kg. हाँ जी, लिख रही हूँ. NST and BPP should only be started at 32 weeks because before that, right? कितना हाइपर हो जाते हो. एक अच्छा बताओ, एक fill in the blank रह गया तो तुम नहीं भर सकते. तुमको सब आता है. You guys are super intelligent and I am sure even if I leave something, you will teach me. Huh? Pregestational means diabetes which is known even before pregnancy. Okay. Okay. Insulin requirement will decrease in labor. Okay. Will decrease in labor. Please remember, night dose of insulin has to be given, but morning dose of insulin has to be omitted. BPP is biophysical profile. Okay. अब मुझे ऐसा लगता है तुम मेरी टांग खींच रही हो. Are you doing that to me when you ask me what is BPP, or you were genuinely asking me? Okay. Anyways, now jokes apart, I'm not saying anything, but neonatal issues is very important. So now the most important one is the newborn baby will have hypoglycemia. Why? Because the baby has high insulin. So जब तक वो fetus था in utero, the baby had hyperglycemia. Okay. Hyperbilirubinemia, polycythemia, hypocalcemia and hypomagnesemia. This is because of prematurity. Okay. Then respiratory distress syndrome and hypertrophic obstructive cardiomyopathy. Okay. Hypertrophic obstructive cardiomyopathy. ठीक है जी, ready to go. अरे भाई भूख लग गई तुम सबको. Energy तो मेरी जा रही है. I'm going to have a chocolate. You all have to send me a chocolate so that I continue with my energy. Right? See, I get energy from all of you, so I don't even need a lunch break. But a chocolate would do. Okay? Okay. Multifetal pregnancy. Which ones are most common? Dizygotic and therefore dichorionic and diamniotic. Okay? Now, monozygotic twins के बारे में क्या पता होना चाहिए? So, if the division happens in 72 hours in the morula stage, it is going to be DCDA. Okay? Between 4 to 8 weeks, that means in the blastocyst stage, it will be MCDA. MCDA is most common type of monozygotic twin. Okay, it is the most common type of monozygotic twin. Na baba, DVT is enough. No book. I am making it for you na. No book. DVT is enough. इसी को जपो, इसी को याद करो, सारा रिविजन हो जाएगा. ठीक है? Between 9 to 12 days, which means at the time of implantation, it will be monochorionic and monoamniotic. After 12 days, matlab when embryonic disc has formed. Then it will be conjoined twins, also called as Siamese. ठीक है? चलो आगे बढ़े. Okay. Markers of dichorionicity. 2 separate placenta is the best sign. Okay. Opposite sex twins. Then lambda sign, which is also called as twin peak sign, which is typically seen when 10 to 14 weeks. Okay. How many number of layers? The best answer is 4. But if they give you an image based question and you see 3 layers, then also it is DCDA. Okay. Then also this will be DCDA. But the single best answer is ideally you should be seeing 4 layers. If the dividing membrane is more than 2 mm thick, this is the least important of all the signs. So in the order of importance. Okay. Alright. Now the donor twin will have IUGR and oligohydramnios. And the recipient twin has polyhydramnios and what else? Polycythemia. So one baby will have anemia, the other baby will have polycythemia, right? But for diagnosis, we need simultaneous presence of oligo and poly, okay? Now the staging is called as Quintero staging, has been a NEET PG PYQ. Please know the staging. Stage 4 has been a NEET PG PYQ. You should know this, okay? Then, please remember the treatment of choice for twin-twin transfusion syndrome is intrauterine surgery. What is the name? Yes, we are going to do a fetoscopic laser ablation of the vascular anastomosis. What are the types of vascular anastomosis in twin-twin transfusion? They are deep artery connected to a deep vein. Okay, so this is what is the treatment of choice. Okay. TAPS may, please remember again, one baby has anemia, the other also has polycythemia. But how do you differentiate it from twin-twin transfusion? Okay, there are no discrepancies in the amniotic fluid. If there is discrepancy in the amniotic fluid, then it is twin-twin transfusion. If there is no discrepancy but anemia and polycythemia, then it is TAPS. Okay. Now, another important complication of monochorionic twins that you should just remember is acardiac twinning. Okay. Acardiac twinning, right? So, this is also seen with monochorionic twins. Okay, bacha? Okay. Now, coming to cord entanglement. This is specific complication of monoamniotic twins. Most common type of conjoined twin. The best answer is parapagus. Okay. Followed by thoracopagus. Right. So, parapagus followed by thoracopagus. Please remember, once you say it is monoamniotic, then the delivery will always be by cesarean between 32 to 34 weeks. Okay. Now, also please remember, when we talk about monochorionic twins, what is the sign? T sign. So, T sign and lambda sign are not same. Okay. Lambda is twin peak. It is dichorionic. T sign is monochorionic. Okay. If they ever ask you delivery, okay, mode of delivery, vaginal delivery will be the answer as long as the first twin is vertex. And cesarean if the first twin is non-vertex. Nothing. I don't want you to know too many details of a cardiac twin. Just remember, a cardiac twin is a complication specific to monochorionic twins. Okay. Monochorionic twins. No, thoracopagus is not more common. You giving me some snapshot of Williams when you don't even know how to read Williams is crazy. That is a 2011 study which said thoracopagus. Today it is 2023. So please don't think that we have not read Williams. We don't read Williams. We understand Williams. You only read Williams, and there is a difference. Okay? Okay, no, acardiac is not same as vanishing. Okay, it's not same as vanishing, bacha. Vanishing hota hai in early pregnancy when one sac disappears. So originally you see only one sac. You were seeing two sacs, but over a period of time, one sac disappears. Okay, chalo. Rh negative pregnancy, only the important points. Please remember, the first thing is to see in the MCQ whether the ICT is positive or negative, because there is no fetal risk. Okay, there is no fetal risk if ICT is negative and if the father is also Rh negative, right? So even father is not Rh negative. Fetal risk is present only if ICT is positive. Okay, sometimes I want to slay it. Usually I am the softie, but sometimes it's nice to slay. Don't you think, girls? Yes? So you'd be a softie sometimes, but then sometimes you have to slay it out. Okay, now antibodies, what is the significant titer? More than or equal to 1:16. If it is less than 1:16, then what do? Then you repeat ICT every 4 weeks. You do it 2 weekly if you see a rising trend. Okay, but otherwise you have to follow it 4 weekly. Okay. If the titer is more than 1:16, you have to see whether the baby is anemic or not by doing an MCA Doppler. And what you look for is peak systolic velocity. And if this is more than 1.5, then you will do cordocentesis, but only if the POG is less than 34. In case the POG is more than 34 weeks, then you will deliver. Okay, then you will deliver. Now, please remember, IUT stands for intrauterine transfusions. So this is done if hemoglobin is less than 8g% or hematocrit is less than 30%. Okay? But if they ask you about hydrops, then you have to know this will happen when hematocrit is less than 15 and hemoglobin is less than 5. Please remember, this is immune hydrops. But nowadays, this is less common than non-immune hydrops. Okay, and in non-immune, the most common reason is cardiovascular abnormalities followed by anemia in the fetus. IUT beta G is intrauterine transfusions. Okay, intrauterine transfusion. Please remember, hydrops is a diagnosis on ultrasound. You have to see any two. Okay, so ascites, pleural effusion, pericardial effusion, what else? And subcutaneous edema. Right. Remember two infections which cause non-immune hydrops. Yes, so among infections, it is parvovirus, which can cause anemia, and syphilis. So these are two infections that I want you to remember can cause non-immune hydrops fetalis, but they're not the most common cause. Most common are cardiovascular abnormalities. Okay. Now, ROGAM is what? It is anti-D. It is the name for anti-D. Okay. Level 2 ultrasound राघव वही है बेटा जो आप 18 to 22 weeks पे कर रहे हो, anomaly scan. Okay, that is what is level 2 because it is done in the second trimester. Remember, it is given IM and it is only when given when ICT is negative. No, HIV does not cause any fetal anomalies. HIV does not cause hydrops. HIV का एक ही problem है, transmission. Okay. Yes, RH is immune mediated eye drops. Okay. 300 micrograms is given at 28 weeks. This is the best time to give anti-D, but you will also give it within 72 hours of delivery, which is given only when the baby is RH positive. So if the baby born is RH positive. Now, 300 micrograms will neutralize 15 ml of RBCs and 30 ml of fetal blood. All right. What test can be done if the bleeding is more than this? So if feto-maternal hemorrhage, FMH stands for feto-maternal hemorrhage is more than 30 ml, then you will do the KB test, Kleihor-Betke test, which is acid denaturation. It is quantitative and it is a lab test. APT was a bedside test. Okay. Chalo. Moving on to preterm labor. So important risk factors: previous preterm labor, infections, abruption, and polyhydramnios. Okay, they are important risk factors. Apart from that, please remember short cervix. The criteria is same, less than 25 mm is important risk factor. Cervical surgery is also a risk factor. KB is Kleihor-Betke test. It's the name of the test. Bacha, Kleihor-Betke. Okay? Right. Now, please remember, this is important because otherwise you get confused. Now, if your patient has previous history of preterm labor and the length is less than 25, then what do? You put a cerclage and you will also add progesterone. Okay. If there is only, history of preterm labor, only से हमारा मतलब है cervix is not short. Then what do you give? Then you give only progesterone. Okay. Then you give only progesterone. So criteria: cervical dilatation more than or equal to 3 centimeters, length less than 2 centimeters is the diagnostic criteria. In case the length is between 20 to 30, okay, then you can do FFN. FFN stands for fetal fibronectin. So it helps in prediction of preterm labor. Right? So then it will help in the prediction of preterm labor. Is that clear to everyone? Now, some of the important things that have been asked as PYQs. Magsulf is given for neuroprotection. Please remember, only when POG is what? I told you, less than 32 weeks. For antenatal steroids, what is the drug of choice? Dexamethasone. What is the dose? 6 milligrams, 4 doses, 12 hours apart, and it is a IM injection. Yes, is that clear to everyone? Okay, tocolytics are only given if POG is less than 34 weeks. And the drug of choice is nifedipine, which is a calcium channel blocker. Indomethacin कब देते हैं? I have already told you, only if the POG is less than 32, as it can cause premature closure of ductus arteriosus. Remember, Magsulf is a tocolytic, and remember, atosiban is also a tocolytic. What category drug? Atosiban is oxytocin receptor antag. Okay, so it can be used as a tocolytic, preferably used in women with heart disease. Okay, so preferably used in women with heart disease. Okay, we move on to fetal monitoring. So when do you say it is oligo? We have written, what is the normal depth? 2 to 8 centimeters. When do you say it's poly? More than or equal to 8. We will take after obstetrics, we'll take a short break, 10 minutes, okay, not before that. Okay, for amniotic fluid index, the normal value is 5 to 24. A lot of places take more than or equal to 24 as poly. Some take more than or equal to 25 as poly. It is absolutely okay. They won't confuse you for that. Oligo is less than or equal to 5, right? And this is all in centimeters. Now, important things that you should know with respect to oligo. It is important. So, ruptured membranes is an important cause. Renal agenesis or obstruction of urine outflow. For example, PUV. What is PUV? Posterior urethral valve. And what is the sign you see? Yes, it's called as the keyhole sign, right? So it's called as the keyhole sign. Apart from that, please remember intrauterine infections and uteroplacental insufficiency. Especially this is a cause of oligo in the 3rd trimester. Okay. SDP Bharat is single deep pocket, also called as deep vertical pocket. Okay. Single deep pocket beta, also called as DVP, deep vertical pocket. Okay. Okay. Potter syndrome का triad क्या होता है? There are renal abnormalities. So this will cause oligohydramnios. Along with that, there is pulmonary hypoplasia. And along with that, there are typical facial features. Okay. Now, amniotic band syndrome में क्या मिलेगा? Limb defects along with oligo. And after limb defects, you can also see craniofacial anomalies. Yes, keyhole sign is seen on level 2 ultrasound. Okay, the anomaly scan. Then, amniotic band syndrome is also called as Streeter's syndrome. Okay, Streeter syndrome. CTEV, I hope you all know, is clubfoot. It is a compression defect. Okay, CTEV is not an anomaly. Please remember, CTEV is because of compression of the baby. Okay. Then a very, very important association is going to be sudden IUD. What is the reason? Cord compression. Okay. So the reason for sudden death is cord compression. What type of decelerations do you see? Yes, we will see variable decelerations. Okay. Usually Potter's is with severe oligo bache, Sairam. So usually the renal abnormalities will be on both sides because it has to be seen with severe oligo. Okay. Polyhydramnios, important associations, which one? So GIT abnormalities, wherever the baby cannot swallow, as well as neural tube defects. Here again the baby cannot swallow, like in anencephaly. So the reason is same in both, right? Whether it is GIT or this. Now, why would somebody have anomalies? Because there may be associated chromosomal abnormalities. See, if the chromosomal makeup of the baby is abnormal, then the baby will show anomalies. Okay. Diabetes is a very important association of poly. Please remember it. Then fetal anemia. The reason here is polyuria. Okay. Yes, any abnormality that can affect swallowing. So whether it is atresia or a cleft palate or even a diaphragmatic hernia, even duodenal atresia. Okay. Then twins may twin transfusion syndrome. Intrauterine infections are more commonly going to cause oligo, but yes, they can cause poly, especially the ones which can cause hydrops. I told you, like syphilis and parvovirus. So these cause hydrops. So they will be associated with polyhydramnios. Okay. Important associations, very, very important. It can cause breathlessness or respiratory distress. If there is so much fluid that it is causing breathlessness, then you will have to do amnioreduction. Okay, the treatment will be amnioreduction. Okay, then premature rupture of membranes, a very, very important association is abruption. Okay, abruption. Then apart from this, please remember it can cause sudden cord prolapse, which is an obstetric emergency. So you have to do an emergency cesarean. The other complications could be amniotic fluid embolism. It is also a risk factor for postpartum hemorrhage because of over distension. Is that clear to everyone? Yes, Bartter syndrome can cause polyhydramnios because of polyuria, but it's not a common thing to come across. So don't think of unique things. Think of more common things first. I would want Purva to annotate it live if you can. If you leave some blanks, maybe later, but try and do it live because that ensures that you are actively doing it. Otherwise, you can do it with the videos again. Okay. Hydrops in general means heart failure. Okay. Now, biophysical profile is also called as what? Manning score. Yes, it is also called as Manning score. Now, complete 5 components, you have to know this. So, fetal breathing, okay, gross body movements, fetal tone, then amniotic fluid. Here we typically see a single deep pocket and NST. Those are the 5 components. Please remember 8 by 10 or 10 by 10 is an absolutely normal score. A score of 6 with normal Likert is called as equivocal. Score of 0 to 4, it means there is acidosis and needs immediate delivery. And whenever we say immediate delivery, it is going to be by a cesarean section. Okay. Who is going to tell me what is a modified BPP? It is a combination of, yes, NST and amniotic fluid. That's what is a modified biophysical profile. Remember, biophysical profile is done using an ultrasound and we do it for a span of 30 minutes. Okay. Chalo. What is this a graph of? Okay, let's do this. SD ratio normally in pregnancy will decrease. But if the ratio is more than or equal to 3 beyond 28 weeks, it's a marker of UPI. This is easy. This is a graph of AEDF. Right? Probably the only 2 images that I'm going to do because Dr. Anil is going to do a complete wrap up of all the images. Right? Okay. So if it is beyond 34 weeks, then you do a termination of pregnancy with cesarean generally preferred over vaginal delivery. If it is less than 34, then you give steroids plus you do a daily monitoring. Okay, you will do a daily monitoring and this is done with NST and BPP. Okay, the graph below is a graph of REDF. Okay. So REDF, reversal of end diastolic flow, right? And please remember, this is typically when we talk about REDF, what is the management? Okay. So management, we'll write it here. REDF, please remember, beyond 32 weeks is termination, again cesarean. Okay. And less than 32, it is going to be steroids. It is going to be Magsalve and it is going to be daily monitoring. Okay. Now, if we ask you what is the best use of uterine artery Doppler, please understand it's not umbilical, it's uterine. So this is prediction of preeclampsia. Okay. So this is for prediction of preeclampsia. If you do it between 11 to 13 weeks, then this predicts early onset preeclampsia, right? And please remember, if you do it later, then it picks up late onset preeclampsia. Early onset is if it happens before 34 weeks. ये postpartum issue यहाँ गलती से आ गया है. Please remember, when we ask you, MCA Doppler is done for, the best use of MCA Doppler is to pick up fetal anemia. Okay, it is to pick up fetal anemia. Now, quickly moving on to postpartum issues, we'll round up obstetrics, give you a 10-minute break, go on to gynecology, and then to the images. So PPH is vaginal blood loss, which is more than how much? Quickly tell me. I need everyone to answer me. Are you with me? How is the Josh? Quickly. Hi, sir. Yes. Cesarean, 1000 ml. Yes, this is ml, not liters, right? When do you say it's primary PPH? If it happens within 24 hours. Okay. And secondary, if it happens beyond 24 hours, up to 12 weeks postpartum. Okay. 12 weeks postpartum. कोई बात नहीं, ग्राफ की चिंता मत करो, डॉक्टर अनिल आने वाले हैं ना, वो भी ग्राफ दोबारा से करेंगे. सी आई एम नॉट डूइंग द इमेजेस, सो आई एम नॉट स्पेंडिंग टाइम ऑन द इमेजेस. देयर इज अ सेपरेट सेक्शन डेडिकेटेड टू इमेजेस, सो हैव पेशेंस. ओके, चलो. रिस्क फैक्टर्स नीट पीजी वाले बार बार एग्जाम में पूछते हैं, सो यू शुड नो दीज. सो प्लीज रिमेंबर, retained placenta, history of MRP, manual removal of placenta. Okay, so manual removal. Prolonged labor, precipitate labor, augmented labor, induced labor, they are all risk factors. Apart from that, any complication of labor like instrumental delivery, they are all going to be risk factors. Remember, certain conditions are important risk factors which you do wrong in the exams. Diabetes mellitus, okay, is a risk factor. Anemia in the mother is a risk factor. Grand multipara is a risk factor. They are PYQs. Obesity is an important risk factor. Placenta accreta spectrum, okay, is again an important risk factor. So don't neglect this. INICT, NEET PG, they are asking this directly, okay. Now, please remember, for prevention, we do AMTSL, right? So for prevention, we do AMTSL. The drug of choice is oxytocin, and this is the most important component. Okay, please remember, it is 10 international units IM. We can give it IV, but it has to be an infusion, not bolus. Who is going to tell me not bolus? Why? Because it causes severe hypotension. Okay, quickly let's fill in the doses. Methergin 0.2 milligram IM. Carbetocin, it is a synthetic oxytocin analog, nonapeptide, right? This is 100 micrograms. Slow IV over 1 minute. Okay. Miso, 600 micrograms oral, WHO recommendation. Trenexa, 1 gram IV over 20 minutes, WHO recommendation given to high risk patients. Okay. What kind of cord clamping are you going to do? Delayed. Controlled cord traction, what is the name? Modified Brand Andrews method. Okay, modified Brand Andrews method. Massage is not done routinely. So please remember, when they ask you which is not a component of AMTSL, the single best answer is early clamping. And then the next best answer is massage. So early clamping to kabhi nahi karna hai. Is that clear? Very rarely when the baby needs resuscitation. That's when you do early clamping. Otherwise it's delayed. Okay. Yes. What we do is intermittent tone assessment. That's absolutely right. Okay. Not massage. So we do intermittent tone assessment. Is that clear to everyone? HIV NACO guidelines say avoid delayed clamping, but WHO clearly says do delayed cord clamping. So that's a conflict. Okay. Let's quickly do this. In the management, your first step should be call for help, start massage, cannula, oxygen, IV fluids, and uterotonics. Usually we will begin with oxytocin plus miso plus Trenexa. This is the order for uterotonics. If this doesn't work, we go to carboprost or methergin. Please remember something that I'm going to write here. When you talk about carboprost, it is not used in AMTSL. Carboprost is used in management. Carboprost is PGF2 alpha. Okay. It is also called as hemabate. Okay. Hemabate. So these are not used for AMTSL. They are used for treatment. Okay. Okay. Quickly, let's understand this. Once you do this and the patient is still bleeding, you move on to balloon tamponade, right? So balloon tamponade, the balloon is going to be filled with 500 ml of normal saline. Yes, carboprost, if you give, it is how much? We'll write it here. Okay. Carboprost for treatment. What is the dose? It is 0.25 milligrams IM and you can give it 8 times. So a maximum of 2 milligrams in a day. Important hai. Now once you have done balloon tamponade and the patient is unstable, you move on to what? Yes, you move on to stepwise pelvic devascularization, which is the first vessel you'd ligate here. So uterine artery, then ovarian artery, then anterior division of internal iliac. Okay. If the vitals are stable, then you can move on to uterine compression sutures. What are those? The ones that we use more commonly are B. Lynch. Only and only used for atonic type of PPH. Remember, if the patient is still bleeding after B. Lynch, you will move on to ligations. Okay, you will move on to ligation. Is that clear? Yes. We can also do uterine artery embolization. You are right if the patient is stable, but the problem is UAE is usually not available easily. So we generally move on to compression sutures. Okay. Chalo. Aage badhe. Is that clear to everyone? Good to go? Okay. Quickly, some short things about these complications and then we're able to almost going to wind off. So risk factors for lacerations are instrumental delivery. What else? If your patient has had precipitate labor. Kisme milta hai precipitate labor? Abruption. Okay? Abruption mein milta hai. And if your patient has occipito-posterior position, then the chances of tears are more, right? Now, please remember the uterus usually will be well contracted in these cases. And for prevention, what are you going to do? You are going to give a perineal support. You can give warm compresses. And you have to control the delivery of head. Okay, you have to control the delivery of head. So you have to maintain the head in flexion. This maneuver, okay, where you control the delivery of head by pushing it in flexion is also called as modified Ridgeon, right? So also called as modified Ridgeon maneuver. All right. When we talk about risk factors for retained placenta, what are the options or what are the reasons? It could be PAS. It could also be a constriction ring. And it could be complications like battledore placenta. And if you are doing a cord traction without giving a counter traction. Okay. Now, what is the management? Please remember, anytime they say there is retained placenta with bleeding, please go and mark it as MRP. Okay, manual removal of placenta. Yes, is that clear? In suction churiata beta, only the smaller lobe is left behind, not the entire placenta. Okay, in battledore, the entire placenta can be left behind. All right. Inversion, cord traction, without counter traction, right? So if you're not giving counter traction, then it is a risk factor. Remember, there will be shock immediately after delivery. Okay, so there will be shock immediately after delivery. Most importantly, please, you will see a mass protruding from vagina, and what will you not feel? Fundus is not felt on PA exam. When you are doing a PA exam, the uterine fundus will not be felt. Okay, what is the management? Yes, so please remember, stop oxytocin. You do the reverse. तुम लोग तो oxytocin शुरू करके आ जाते हो. So no, stop oxytocin. Plus, what else are you going to do? IV cannulas, and then you begin with manual repositioning. Please remember, if the placenta is attached, do not remove placenta. Okay, if it is attached, do not remove placenta. Is that clear to everyone? Okay. Amniotic fluid embolism is a rare complication, so it should be a diagnosis of exclusion. Okay. How will the patient present? There is sudden onset of breathlessness. So cardiorespiratory failure. Okay. So cardiorespiratory failure. And iska matlab hai, there is breathlessness, then this is followed by hypotension, and this is followed by shock and coma. Right? Please remember, this has a high mortality rate. SOB kya hota hai, batao? Sudden onset of breathlessness. Okay, sudden onset of breathlessness. Okay. Second phase, very few women will enter the second phase and they will have DIC. They will begin to bleed. Okay. Please remember, definitely yes, cesarean section, instrumental deliveries, they are risk factors. Okay. Now, moving on to quickly the second last part, which is going to be changes of purpurium, and we have to do it faster, and we move on to some things that you need to know about labor. Alright, so let's do this. Immediately after delivery, uterus is at the level of umbilicus. If they ask corresponding to what weeks, answer it as 20. The cause of uterine pains is oxytocin. Okay, it is going to be oxytocin released because of suckling. Okay, postpartum shivering is because of blood loss. But if they ask you which drug, then it is misoprostol. Remember, misoprostol causes hyperthermia with chills. Yes. Okay, first 24 hours there is no change, and then it will involute as 1 finger breadth per day. So on the second day it will lie 1 finger breadth below umbilicus. At 1 week's postpartum it will lie midway between umbilicus and symphysis pubis. It becomes a pelvic organ at 2 weeks. If they ask you in days, it is 10 to 12 days. Complete involution, 6 weeks. Okay. Lochia, rubra, then serosa, then alba. Rubra kab tak hota hai? Rubra for 3 days. Then 5 to 9 days usually, or from 4 to 5 days to 9 days, it's serosa, and beyond 10 days, it is usually the alba. Right? Can be released up to 4 to 6 weeks. The single best answer is 4 weeks, but up to 6 is normal. External os का shape कैसा होता है? Transverse slit. Nulliparous में it is circular, but after delivery it will never be circular. It's a transverse slit. Most common nerve injury, lateral cutaneous nerve of thigh, right? A branch of the femoral nerve. Postpartum blues का onset होता है within 2 to 3 days, and the cause is sudden fall of E and P, right? Sudden fall of E and P. Usually postpartum blues will resolve within 2 weeks. If they go beyond 2 weeks, then it's not postpartum blues, probably depression. Yes? HCG returns to normal by 2 weeks. जब भी कुछ समझ में ना आए और normal पूछा है, answer it as 2 weeks. Okay. Menses will usually return by 6 to 8 weeks in non-breastfeeding. Cardiac activity, 2 weeks. Okay. Cardiac activity, 2 weeks. Breastfeeding should be started within 1 hour. Okay. It should be started within 1 hour. Absolute contraindication का best answer है galactosemia. Okay. Galactosemia. But other answers are active, untreated, okay, pulmonary TB. Then herpes lesions on the breast, chemotherapy and radiotherapy, right? So chemotherapy and radiotherapy. Okay, I'll show you the previous slide, don't worry. I said most common nerve injury is lateral cutaneous nerve of thigh, postpartum blues 2 to 3 days, and the reason is sudden fall of E and P, right? Resolve within 2 weeks. The other things I have written here. Okay. Now, colostrum में ज़्यादा क्या होता है? So mainly it is immunoglobulins and proteins, right? And it has more of sodium and chloride. Okay. It has more of sodium chloride. Please remember it has less of fat, less of carbohydrate, less of potassium, less of calcium. Yes, definitely most of it is water. Okay. Contraception of choice in breastfeeding women. Single best answer is POP followed by IUD. RTH bache is radiotherapy if the woman is on chemotherapy or radiotherapy. Okay. Galactosemia, baby bacha, these are absolute contraindications of breastfeeding. So galactosemia in the bacha, not in the mother. Okay. Okay. Now, if a woman is non-breastfeeding, you start contraception by 3 to 4 weeks. If she is breastfeeding, then you should start it by 3 months. So definitely start it at 3 months. Okay. Moving on to the last phase of obstetrics. So smallest diameter of the inlet is which one? It is obstetric conjugate. Right? So it is obstetric conjugate. But which is the only diameter that can be measured? Diagonal. Okay? Diagonal conjugate. What is the relationship? Diagonal conjugate minus 1.5 centimeters. Okay, gives us the obstetric conjugate. So this is usually 12 and this is usually 10.5. Now, please look at this diagram because these are important for NEET PG. So, remember the plane of least pelvic dimensions. So this plane passes through the ischial spines. Plane of least pelvic dimensions is same as plane of obstetric outlet. It is also same as plane of mid pelvis. Okay, it is same as plane of mid pelvis. Now, please remember the 3D space. Listen to me very carefully. The 3D space above this plane is mid pelvis. And the 3D space below this plane is obstetric outlet. Is that clear? So obstetric outlet is 3D space below the plane of ischial spines. Mid pelvis is the 3D space above the plane of ischial spines. Okay, is that clear? Yes. Please remember anatomical outlet will pass through ischial tuberosity, not ischial spine. Okay, ischial tuberosity. Also remember plane of greatest pelvic dimensions passes through space between S2 and S3 vertebra. So disc between S2 and S3. Is that clear? Yes. Please understand if it is outlet, whether obstetric or anatomical, what you should see at the back should be coccyx. If they are not showing you the coccyx, then it is not the outlet. For obstetric outlet, it will be the body of coccyx. For anatomical outlet, it will be the tip of coccyx. Is that clear? Is that clear to everyone? Okay. Then, which diameter is being measured here? So when you go from lower border of symphysis pubis to the sacral promontory, this is diagonal conjugate. But if you go from inner surface of symphysis pubic, right? So if you go from inner surface of pubic symphysis to the sacral promontory, then which diagram is this? Then it is obstetric conjugate. So sometimes they ask you like this. So if you go from inner surface, it's obstetric. If you go from lower border, it is diagonal. Upper border se kya jata hai? True conjugate. So from upper border to sacral promontory is going to be true conjugate. Okay. Is that understandable? So this is important. I said, if they show you in a diagram, whether it is outlet or not, see if they are showing you the coccyx. Okay. Only and only if they have marked to the coccyx, then only it is outlet. Otherwise, it's not outlet. So in the obstetric outlet, the entire body of coccyx comes. Whereas in the anatomical outlet, it will be the tip of coccyx. So it goes from pubic symphysis lower border, ischial tuberosities to the tip of coccyx. Is that clear? Okay. Obstetric conjugate is inlet, bacha. It's inlet. Okay. It's an inlet. Yes. From symphysis pubis to the sacral promontory. Okay. From inner surface of symphysis pubis to sacral promontory is obstetric conjugate. Okay. Now, please understand we have done these things in routine classes. The only purpose is to show you that if they do it in the diagram or if they write it verbally or in a written format, how are you supposed to know this? Okay. I already repeated the coccyx things twice. Okay. I'll do that again later. But as of now, as I said, sometimes they give you a diagrammatic representation. Suppose they show you the yellow area and they ask you, what is this yellow area? Can you tell me what will you answer it as? What will you answer the yellow area? You have to say it is mid-pelvis. If they ask you what is the purple area, can you tell me what is the purple area? It is the obstetric outlet. If they ask you what is this red line that I am drawing, the red line is anatomical outlet. Is that clear? Okay. Perfect. Chalo, ab aage badhte hain. How do you identify the type of pelvis? So gynecoid pelvis, you will have a round inlet. Almost we say circular. It may be slightly oval, but it is usually a round inlet. Okay. What about android pelvis? The inlet is heart shaped. Okay. It is heart shaped. Anthropoid, it is antero-posteriorly oval. So AP diameter will be more than transverse diameter. Right? Platypeloid, it is transversely oval pelvis. So transverse diameter will be more than AP. Right? So now, please remember these important things. That in android pelvis, what you see is OP position. Right? So if they ask you ROP is seen in which pelvis, the answer has to be android. Right? But if we say persistent OP, okay, if we say persistent OP or if we say direct OP, then what is the pelvis? Then it has to be anthropoid. Okay? Then it has to be anthropoid. Even face to pubes is anthropoid. Okay? Then also it will be face to pubes. Is that clear? When we say platypeloid, platypeloid mein kaun sa milta hai? In platypeloid you will see face presentation. So it is very different from face to pubes. Okay. ROP is right occipito-posterior bacha, which is the most common position in OP. Hai na? So most common position in OP is ROP. So that is seen in android pelvis. Is that clear? Okay, brow is also seen in platyploid. Okay, brow is also in platyploid. Yes, platyploid is often called as flat gynecoid. Okay, so flat gynecoid is actually platyploid. Is that clear? Okay, perfect. I hope you can all identify these because Dr. Anil is going to do the Leopold maneuvers. I'm sure he's going to show you. But yes, image A. So this is A, B, C and D. Okay, somebody is asking about DTA. DTA can be seen in both android as well as anthropoid. But the single best answer for DTA will be android. Okay. Now, what is image A? This is the fundal grip, right? Also called as Leopold 1. What is B? Lateral grip, Leopold 2. Okay. C कौन सा है? Pollex. This is Leopold 3. And image D is pelvic grip, also called as deep pelvic grip. And this is Leopold 4. Right? So that is Leopold 4. Don't worry, as I said, images Dr. Anil is also going to cover in detail. Okay. Pollic is 3. Now, quickly learn this with me. Triangular fontanelle is what you have to focus on. Okay. If triangular fontanelle is close to the sacrum, this is OP. And if it is my left or your left, it will be patient's right. So this is ROP. So this is just the other way of showing you ROP. Here, when we look at the triangular fontanelle, it is close to symphysis pubis, right? So which means this is OA, occipito anterior. And if it is my right, it will be patient's left, right? So this is left occipito anterior. Please remember the most common position in labor is LOT. In late labor, yes, it will become LOA. Okay. So most common is LOT and in late labor, it will become LOA. Okay. Now, these diameters, you can see them later easily. Everything is marked and labeled, right? The diagram is just for you to identify kahan se kahan ja raha hai. Exam mein kaise dete hain? They give you this, like suboccipitobregmatic. Either they will ask you how many centimeters or they will ask you which presentation. So this is going to be when the head is well flexed, which means vertex. So vertex is well flexed. Okay. Similarly, I have left this one for you. Submentobregmatic is also 9.5 and this is seen in which type? Yes. This is seen in face when there is full extension. Brow is partial extension. So you should know the engaging diameter and the presentations. Is that clear? So you can see them later. I've put the values also for you. Sometimes they are asked as direct MCQs. I have filled up most of the ones for you. Okay, you wanted to see which one? This one? So I said look at the position of the triangular fontanelle. Right? If it is close to sacrum, it is OP. If it is close to symphysis pubis, it is OA. If it is my left, the answer will be patient's right. So the first one is ROP. If it is my right, the patient's left. So third one is LOA. Left occipito-transverse is the most common position here. Okay. Now, these are graphs. They have been PYQs earlier. They are not used now, but just have a general idea. So graph A, okay, graph A here is what? It is prolonged latent phase. Graph B here is prolonged active phase. And C is what is the graph of arrest of active phase. Okay. Now please remember, arrest of active phase, the most common cause is cephalopelvic disproportion, Okay, and therefore usually the management of this arrest is emergency cesarean. How will you know if it is arrest? So what tells you CPD? If you see words like caput and molding. Please remember, when you see these words, never ever mark instrumental delivery. Instrumental delivery is contraindicated in CPD. So when you see these words, it should be straight cesarean. Is that clear? Okay. Now, this is something that I have taught in class. This is just for all of you. The newer guidelines have been given when to say it is arrest. Okay. It is same as what we have taught you in the class. So please remember, just go through them. I'm not going to read them out right now. The definitions of arrest are important. So arrest of active phase and arrest of second stage. So the guidelines have been given. They are exactly same as we have taught you in the class. Now, so you can just see them later. There is no hurry into this. But please remember, when we talk about WHO partograph, okay, and we are asking you active phase, then this is at and beyond 4 centimeters. But if they say WHO labor care guide, okay, so if they say WHO labor care guide, then it is at and beyond 5 centimeters. Okay. ACOG guidelines is what I've given you, where they consider active phase as 6 centimeters. Okay, where they say active labor as 6 centimeters. So there are different terminologies. You just know the terminologies and answer accordingly. Okay. Now, OP बार-बार exam में आता है. So what words when written, it will tell you that it is OP. So if you see infraumbilical flattening, limbs are towards the midline, fetal back is towards the flanks, fetal heart rate is also heard close to the flanks, anterior shoulder is away from midline, okay, so anterior shoulder away from midline, head is not engaged, labor will be prolonged, okay, and anterior fontanelle is felt easily. So this is how you will know it is occipito-posterior. As I said, the most common position is ROP, and in general, management of prolonged labor here is what? Wait and watch, because it is going to rotate. Okay. A few things that you should know about breech. Now please remember, the breech, if she comes at 37 weeks, the first thing you have to see is, are there any contraindications for external cephalic version? Yes. So please remember, if there is no contraindication, then the answer is do ECV, and the best time to do it is 37 weeks. Okay, the best time is 37 weeks. Anterior shoulder bache, anterior fontanelle bache, because the head is deflexed. Okay, in OP, usually the head is deflexed. Okay, so anterior shoulder will be felt, anterior fontanelle will be felt more easily on a PV exam. Okay. Posterior PA पे मिलेगा. Posterior you can feel on a PA exam. Here we are talking about PV examination. So PV पे anterior fontanelle, as the head is deflexed. Okay. Okay. Now, please remember, if ECV is contraindicated, then in general, cesarean is preferred over vaginal delivery. Okay. Then in general, cesarean is preferred over vaginal delivery. Is that clear? Now, in your exams, they often ask you contraindications for ECV, because that is what you have to look for in the MCQ. If contraindications are absent, you do ECV. If contraindications are present, then you do cesarean section. Yes. So now remember, if it is a footling breech or a stargazer breech. Some people were asking me, stargazer is only used in terms of breech, not with vertex beta. Okay. Then please remember, if the membranes are ruptured, we will never do a ECV. if the pelvis is contracted, placenta is previa, right? Apart from this, areas where they confuse you: previous cesarean, pre-eclampsia, okay, IUGR, especially if it is with oligo. These are also important contraindications, right? So these are the contraindications for an external cephalic version. Yes, anytime you see uterine anomalies or even fetal anomalies, right? So fetal anomaly to likha hai. So uterine anomalies, fetal anomalies, they are also going to be contraindications. Is that clear? Yes. ये नीचे वाले तीन relative हैं, but they are contraindications. So that's how they twist in the exam for you. Okay. Now this is something which is very important for NEET PG. Contraindications for induction of labor. Right? So please remember, some of these are already filled. I am filling the others for you. So contracted pelvis, placenta previa. Okay. If the patient has had a classical cesarean, active lesions of genital herpes, malpresentations, especially if they talk about transverse lie, cervix or cancer cervix is an absolute contraindication, cord prolapse, okay, then contracted pelvis, these all are going to be important contraindications. Is that clear? So please remember, we are not going to do it. Yes, more than or equal to previous 3. Yes, but then they won't really give you that. They'll give you classical. Had it been LSCS, then we take more than or equal to 3 previous LSCS. Also similarly, history of rupture uterus is very, very important. Okay? Remember this. I want you to remember Bishop's score. They will not ask you to calculate in NEET PG. Calculation is important for inicet. Know the components of Bishop's. Remember, dilatation is the most important component. And remember that position is the least important component. Remember, the total score is out of 13. Anything which is less than 6 is considered as unfavorable. Okay, is considered as unfavorable. So you will have to do cervical ripening. Now very, very essential, because NEET PG people confuse you. We will use PGE1, we will use PGE2, but we will never use PGF2 alpha or carboprost for induction of labor. It is not used for induction of labor. Don't do this mistake. You can use Foley's catheter, you can use laminaria tents. They are mechanical methods, right? But we will not use PGF2 alpha for induction. Is that clear to everybody? Yes? Okay. So this is it. So we finish obstetrics with this, right? And as I said, the videos, the annotated PDF, everything will be uploaded, but we are left with gynae and I am behind schedule a little, right? So we're left with the entire gynecology. Do you want to take a 10-minute break or a 5-minute break? Okay, so we'll just take a 5-7 minute break for essential services. We join back for the gynecology session. Till then, yes, you have to tell me, how did you find the obstetrics session? Quickly, and I'm going to write modified Bishop's for you. So modified Bishop's, everything remains the same. Effacement is replaced by cervical length. Okay? So effacement will be replaced by cervical length. Right? So I hope I've made it high yielding. I've covered everything. Please do this. You will not get anything out of it. Apart from that, I hope your concepts are good. So just a 5-7 minute break and we are going to join back for the gynecology session. And after that, we are going to have the image-based session as well. So let's keep it rolling. Let's not make it a longer break. Jaldi jao or jaldi aao. No, lunch break after Dr. Anil's session. बीच में कुछ खा लो ना, हम तो बोल रहे हैं, लिख भी रहे हैं, तुम लोग खा लो. Okay? हाँ जी, everyone, ready, good to go? Okay. चलो, Recorded version डाल देंगे यार, पहले live तो करने दो. Okay. हाँ जी. So now, so we're going to begin with gynecology, and we're going to start off. Again, we're going to cover the most important things, the most relevant ones, the ones which are most likely to be asked in the exam, right? Is it clear? Okay. So let's start off, and everyone ready? Focus, try and answer. If you can't write, you can write it later, because if you do that later, it will be like a revision again for you. So Abhi, you listen, try and answer, try and recall, and maybe you can fill it up later like a workbook itself, right? So it will be acting like a spaced revision for you. Okay? Chalo, shuru kare. Love you all. Take care. I'm going to try my best again. And let's go. Okay. So, easy things now. So please remember, when we talk about the embryonic origin from the uterus, we know it is Mullerian ducts. We know it is called as paramesonephric ducts, right? What is the main support? It is always going to be answered as levator ani. But if we ask you in the ligaments, right, what is the main support? Then it is going to be cardinal. After that, it is going to be uterosacral, and the third ligament which is a main support is which one? Pubocervical. Now very important, please remember, broad ligament bacha is not a support, okay? It's a false name. Now if we ask you which ligament maintains anteversion and anteflexion, it is going to be round ligament. If you can mark two answers, it should be round plus uterosacral. But as I said, the single best answer is going to be round ligament. Okay. Now, what is the lining epithelium of endocervix and uterus? It is continuous. So it is columnar epithelium, right? So it is single layer columnar epithelium. Whereas when you talk about ectocervix, we all understand that this is going to be squamous. है ना? Now, although the main source of blood flow to the uterus is uterine artery, it's already written there, but you have to remember what also contributes is going to be the ovarian artery. Why? Because they form an anastomosis, right? So through the anastomosis, ovarian artery also contributes. Quickly, lining epithelium of fallopian tubes. Many PYQs from here. So this is, yes, ciliated columnar. Okay, so this is going to be ciliated columnar. What is the main reason for transport of conceptus? It is going to be peristalsis. So that is why whenever there is a reduction in peristalsis, it can cause ectopic. Narrowest part, आप लोग गलत करते हैं, है ना? So what is the narrowest part? It is going to be intramural part, which is also called as interstitial. Okay? What about the area where we do ligation? This is going to be isthmus. Beta, isthmus is not the narrowest. It is narrow. But intramural is the one that is narrowest. Okay? Ectopic pregnancy is most common at ampulla, because this is the site of fertilization. Also because it has a number of plicae. Plicae are mucosal folds. Please remember, round ligament is attached anterior to the fallopian tube, whereas ovarian ligament is attached posterior to the fallopian tube. And which out of these three is at the top? The most superior structure, fallopian tube. Right? So most superior is fallopian tube. Okay? Perfect. Very good. Now, ovaries are attached via the ovarian ligament to the uterus, right? And this ligament attaches to the lower pole of ovary. So it goes from lower pole of ovary and then it will go to the uterus. Okay. Now, when it comes to pelvic side wall, what ligament is this? Infundibulopelvic. Okay, it is infundibulopelvic. No, this is not Pisca sex sign, bache. Pisca sex is unequal growth of the uterus due to lateral implantation, right? So that is what is Piscasex sign, okay? Now, when we talk about ovaries, please remember they arise from genital ridge. I told you as early as 8 weeks, okay? As early as 8 weeks. Now, please remember the other name for infundibulopelvic is suspensory ligament, and it is important because it has the ovarian artery and the ovarian vessels. And we will clamp this ligament only when, what are we going to do? Only when oophorectomy has to be done. So when you have to do oophorectomy, then you will clamp the infundibulopelvic ligament. If you are not doing oophorectomy, then you have to spare this ligament. Okay, so then you have to spare this ligament. Now please remember the normal commensal is lactobacillus, which is also called as Doder-Lein's bacilli. Right? Now because of this lactobacillus and estrogen, so these are the two things which will maintain the vaginal pH acidic between 3.5 to 4.5. So normal pH has to be less than 4.5. Remember, vagina will lack glands. So the main source of secretion has to be answered as cervical glands. Please don't answer it as Bartholin's. Bartholin's will only secrete at coitus. Okay. So Bartholin's gland will only secrete at coitus. They don't secrete secretions all the time. Okay. Now, which cells do you see predominantly under estrogen? It is going to be the superficial cells. They are pink, big cells. But the most important thing is that these cells under estrogen will have a pycnotic nucleus. Right? So the nucleus is going to be pycnotic. Okay. With progesterone, what kind of cells? Intermediate. And intermediate cells usually stain blue. Okay. They stain blue. Upper 1/3 of vagina. This is as per the anatomy textbooks. Is derived from the Mullerian ducts. Whereas lower 2/3 is derived from urogenital sinus. Okay. So UGS. Is that clear to everyone? Hanji. Parabasal cells कब मिलते हैं? In the absence of estrogen and progesterone. Right? So parabasal is when there is no E and P like in post-menopausal woman. Okay? Chalo, आगे बढ़े. Now, moving on to vulva. So now please remember the greater vestibular glands are the ones which are also called as Bartholin's. They open at 5 o'clock and 7 o'clock position. And where do they open? They open in the vestibule. Okay, so they open in the vestibule. But what is this area? So they actually open between labia minora and hymen. Do you all remember what is vestibule? Vestibule is the area between the labia minora, right? So it's the area between the labia minora, right? Okay. Now please remember when we talk about clitoris, it is derived from genital tubercle. बहुत बच्चे genital ridge and tubercle में confuse हो जाते हैं. So right, this is genital tubercle. Labia minora कहाँ से आते हैं? Labia minora are derived from, right, so there is a genital tubercle, there is a genital fold, and there is a genital swelling. So labia minora will come from genital fold and majora will come from genital swelling. Is that clear? Okay. Quickly, let's do this. Now, some important procedures. Okay. Vestibule, बच्चे मैंने बताया, it is the area between labia minora. So, sometimes the exams just ask you, where does Bartholin gland open? The answer is vestibule. It opens in the vestibule. Okay. Now, fixative is what? 95% ethyl alcohol. And please remember, when we talk about pap smear, ye every chhod do, but what you have to know is that pap smear can be taken any time. There is only one contraindication, and that is active bleeding. Otherwise, you can take it any time. We will do the frequency of testing when we go on to cervical cancer. Okay, we'll talk about frequency there. The diagnostic test for cancer or dysplasia has to be a biopsy. Okay, it has to be a biopsy. So please remember, anytime the MCQ says patient has come with bleeding and the cervix appears abnormal, which means they may say there is an erosion there, they may say there is a growth there, they may say there is an ulcer there. So whenever there is a visible growth, you have to take a punch biopsy. Don't answer it as pap smear. If it is visibly abnormal, it has to be a biopsy. Okay. Now, when we talk about ectocervix, please remember we are doing a screening for squamous cell cancer, which is the most common one, right? Which is 75%, and we take sample from what part? Yes. The most common site is transformation zone. Okay, it's going to be a transformation zone. Endocervix, but this is where you do it wrong. If they ask you cancer seen in endocervix or most common cancer seen in endocervix, the answer changes to adenocarcinoma. Okay, which is the second most common cancer. Okay. Colposcopy mein what do you apply? 3 to 5% acetic acid. Okay, and the areas of dysplasia will appear white. Okay, they will appear white. Now, any area that appears white or area with pale mucosa or area where there is irregular contour, these areas need to be biopsied. Okay? And then specifically sometimes we'll ask you, colposcope has a green filter. What is it used for? So this is primarily used for identifying abnormal vessels, and then we will take the biopsy from these vessels. Okay. When do you do endocervical curettage? So when the pap smear report comes as HCIL or it comes as AGUS. Do you know what is AGUS? Atypical glandular cells. Okay. Then we will take a biopsy from the endocervix as well. Okay. Please remember, you will not take a biopsy if or endocervical curettage if the woman is pregnant. This is an important contraindication. Okay. Gadbad nahi karna. Loop or leap, दोनों ही same चीजें हैं. They are same things. It is a minor OPD procedure, and remember that this is done under local anesthesia. Okay. And it is the treatment of choice. These days, it is the treatment of choice for what? Sin 2 and Sin 3. Okay. It is a treatment of choice for Sin 2 and Sin 3. Now, please remember it is both diagnostic as well as therapeutic, because you are removing the entire transformation zone. So, it is therapeutic as well. Okay. What are the advantages? It is a short procedure. Takes around only 15 to 20 minutes. And also, will it cause bleeding? The answer is no. So please remember, bleeding is not a side effect. Why? Because you're using electric current for both cutting as well as cautery. So the current is set at cutting also and cautery also. Is that clear? Chalo. Moving on to hysteroscopy. Now, generally, what you have to remember is that the pressure is around 50 to 70 millimeters of mercury. The upper limit is 100, right? So, we should not go beyond 100. That is the upper limit. Okay? Then, if it is a monopolar cautery that you are going to use, then which fluid will you use? You will use glycine or sorbitol. The most common one is glycine, which means they are electrolyte deficient. Yes, they are electrolyte deficient media. Okay. Can you tell me what is the upper limit? So upper limit in terms of what are we talking about? We are talking about fluid overload for the patient and fluid deficit for the doctor. It is the same thing. So it is going to be 1 liter. Okay. It is going to be 1 liter for this. Whereas if they ask you what fluid will you use with bipolar cautery, then you will answer it as normal saline or ringer lactate, which means electrolyte rich media. And please remember the upper limit for this is 2.5 liters. Okay, then the upper limit is 2.5 liters. क्या आपको ऐसा लगता है when we are going through DVT, do you realize how many PYQs have come from it? Yes or no? Yes, so as you do this, you will realize, अरे ये इस एग्जाम में आया था, ये इस एग्जाम में आया था. So please stick to DVT, revise it as many times as possible, right? It covers both the things, concepts, one-liners, application, everything. ठीक है? चलो, HSG. Please remember, HSG is the IOC for tubal patency. Okay? Now, when we say on HSG, if you see a bilateral block, whether it is cornual block or it is a distal block, what is the next thing? Your answer should be diagnostic laparoscopy plus chromoperturbation. Okay, so diagnostic laparoscopy plus chromoperturbation. Which dye do we use in chromoperturbation? Methylene blue. आप लोग confuse करते हो. Here we are asking you dye for chromoperturbation. So for chromoperturbation it is methylene blue. But if I ask you what dye do you use in HSG, it is a iodine dye, water soluble, right? So here it is going to be iodine water soluble dye, but for chromoperturbation it is methylene blue. It is usually done anywhere between day 5 to day 11, most commonly day 10. You have to do it in the post-menstrual phase. Okay, so post-menstrual phase. Important contraindications. Pregnancy, never do it. Okay, then pelvic infection. If there is a current pelvic infection, untreated TB, dye allergy are some of the other important contraindications. Okay, these are the other important contraindications. Bache wo na Shabnam, that is important for inicet. So if you go to inicet sections, we have discussed about components of pap smear. It is not required here, right? So here currently DVT is primarily where you need a little more width than inicet, but you also need some more depth. Right, so width ज़्यादा चाहिए for NEET PG exams, उतना depth नहीं चाहिए. So you don't need to know the components of the dye of pap stain for NEET PG at least. Okay. Yes, active bleeding, yes, but when we say active bleeding, it should mean active bleeding. It doesn't mean spotting. Okay. Asherman's is not a contraindication, beta. Definitely not. Asherman's में आप HSG करके diagnosis बनाते हो. Okay. Now, please remember, when we talk about menstrual cycle hormones, some very basic questions, but they are important. Okay? FSH stimulates the growth of the follicle, right? And what does it promote? The release of estrogen. So, under the effect of FSH, granulosa cells will predominantly secrete estrogen. On the other hand, when we talk about LH, it would be something different. So LH will stimulate the production of androgens, and they come from the theca cells, right? Please remember, this is usually the theca interna cells. Okay. Now, we all know LH surge is very, very important. So what is it dependent on? It is dependent on high level of estrogen for at least 48 hours, right? So high level for at least 48 hours. Okay, now progesterone is produced by corpus luteum, है ना? And it stimulates what? Secretory changes in the endometrium. So its main purpose is to stop proliferation and bring about secretory changes. Corpus luteum has a lifespan of 14 days. Please remember, it is maintained by LH. But if I ask you corpus luteum of pregnancy maintained by, then what is the answer? Then the answer will be HCG. So corpus luteum of pregnancy is HCG. Also, please remember, corpus luteum mainly secretes progesterone, but it also secretes estrogen. It also secretes inhibin A and relaxin, right? So these are all the substances which are produced by corpus luteum. It's important, but the single best answer is progesterone. Okay, this one I have already labeled. I will just tell you how to do it. If you see a single peak at the time of ovulation, then it is LH. If you see two peaks, okay, one before ovulation and one small at ovulation, then this is FSH. If you see two peaks, okay, one before and one after, okay, so if you see two peaks, one before ovulation and one after ovulation, that is the purple hormone, then this is what is E2. And if you see only a single peak, okay, only a single peak after ovulation, then it is progesterone. So that's what you have to see. How many peaks? If it's one and ovulation, LH. Two, one before and one at, estrogen. Two, one at or just before and one after, that's estrogen. And only one peak after ovulation, that's what is progesterone. Okay, is that clear? Okay, now please remember, as I said, secretory phase is under the effect of progesterone. What are the classic histopath findings? So you have to remember the findings are subnuclear vacuolation and corkscrew glands, right? So subnuclear vacuolation and corkscrew glands. Is that clear to everyone? Now please remember, subnuclear vacuolation early phase में मिलता है and corkscrew glands later phase में मिलता है. And when we say histopath, it means we are talking about endometrial biopsy. So these are findings on endometrial biopsy. Is that clear to everybody? Okay. Proliferative will be under the effect of estrogen. What is the finding on histopath? Yes, they will be tall glands. The typical word we use is telescope-like glands, and we will see pseudostratification. Okay, so we will also see what? Pseudostratification. Is that clear to everyone? Perfect. Chalo, aage badhe. So this is important classification for AUB, and you are going to get questions from AUB. So when you say P, it means the cause is polyp. A stands for adenomyosis. L is leiomyoma. I hope, which you know. We'll talk about days. Don't worry, Suresh. Abhi alag se sare days likhenge. We'll enumerate them at one place. कौन सा डे पे कौन सा टेस्ट करना है, कौन से फेज में करना है. I'll enumerate everything at one place. Okay. M, please remember, is malignancy, and also M is used for hyperplasia. Coagulopathy, ovulatory, ये सब मैंने भर दिया. Now please remember, if somebody has abnormal bleeding because of OCPs or IUD, then it comes under iatrogenic. Okay, then it comes under iatrogenic. PCOS can cause abnormal bleeding and it comes under ovulatory. Endometritis comes under endometrial causes, right? So remember these are important. Also please remember, when you say menorrhagia, okay, it means regular and heavy bleeding. When you say polymenorrhea, it means regular and short cycles. Okay. When you say oligomenorrhea, then it is regular plus long cycles. Okay. And what is the criteria to say heavy bleeding? More than 8 days or more than 80 ml. Okay. When do you say it's short cycles? If it is less than 24 days. When you say long, if it is more than 38 days, right? Intermenstrual bleeding ke liye, what is the term we use? Metrorrhagia. So metrorrhagia is intermenstrual bleeding. Is that clear? Perfect. Very good. Now let's look at this. Very, very essential. Now when we talk about most common cause of AUB in an adolescent girl, it's anovulation. But when we ask you second most common cause, and these are important NEET PG questions, then this is coagulopathy. Okay? Always, whenever a patient comes with abnormal bleeding and she is in the reproductive age group, always rule out pregnancy first. Okay? As a rule of thumb, you have to rule out pregnancy. Okay? Most common cause of AUB, as I said, they will keep asking you. Whether you talk about adolescent girl or perimenopausal women, the answer should be anovulation. Okay, the answer is anovulation. If they ask you in a small girl, then this is foreign body, or sometimes if foreign body is not there, then we can write it as non-specific vulvovaginitis. But foreign body is the best answer, followed by non-specific vaginitis. Is that clear? Okay. Now, when we talk about tests, various tests and when should we do it? So, serum progesterone is done on day 21 of the cycle. Okay. And values more than or equal to 3 nanograms means the cycle is ovulatory. Okay. Endometrial biopsy. When do you do it? Day 26, which means it is done in which phase? Secretory phase or post-ovulation, right? So, it is done in the secretory phase. Okay. Now, please remember when we talk about basal body charting, BBT chart, if it shows a biphasic chart, which means in the first half, the temperature is low, in the second, the temperature is high, then the cycle is ovulatory. What is the type of cervical mucus under progesterone? It is thick, it is scanty, and it is viscous. है ना? So, thick, scanty, viscous. 0.5 degrees Fahrenheit, right? So, generally we say 0.5 degrees Fahrenheit. Yes, the range is 0.5 to 0.8. Okay. Under estrogen, it is thin, it is copious, watery, and very, very importantly, it shows furning and spin barcate. Okay. Spin barcate is stretching, furning is furning. Now, furning ke liye we need high levels of estrogen and we also need high levels of NaCl, right? So, high estrogen, high NaCl. Okay. Biphasic का मतलब है बेटा, ग्राफ में दो peaks दिखेंगे, दो अलग-अलग phase दिखेंगे. In the first phase, the temperature is on the lower side, and in the second phase, after ovulation, it is on the higher side. So, two phases, okay, low and high. Yes, all these are based on 28-day cycle. That's right. Okay, now very important, definitions are very often asked in the exams. So, primary amenorrhea ka general answer is absence of menses, right? But then you have to say what have they written about secondary sexual characters. So, if it is without secondary sexual characters, then it is, sorry, here, 13 years. And if it is with secondary sexual characters, then it is 15 years. What will you answer if they mention nothing about secondary sexual characters? Then the single best answer is 15 years. Absence of menses by 15 years. Okay. Now let us look at this. If the MCQ says breast development is present, any MCQ which says breast development is present and they ask you next step, then the answer should be ultrasound. Why? Because breast development means the ovarian, ovary as well as higher centers are working properly, right? So, you suspect some problem to the outflow tract, okay? So, just a minute, okay? So, you prefer some problem with the outflow tract, right? So, always answer it as ultrasound. Now, when uterus is also present, this can be imperforate hymen or it can be transverse vaginal septum. Which is more common out of the two? Imperforate hymen. What is the emergency presentation? Acute urinary retention. Okay, acute urinary retention. What words will help you in telling that it is, imperforate hymen? So, apart from cyclical pain, which can be present in both, if you see a bluish bulging membrane, right? So, if you see a bluish bulging membrane and cough impulse positive, then these go in favor of imperforate hymen. Also, please remember, hematocolpos is more common with imperforate hymen, whereas hematometra is more common with transverse vaginal septum. Why? Because this septum is usually present in the upper 1/3 of vagina, right? So, usually it is in the upper 1/3 of vagina. So, hematometra is more common. Okay? Now, suppose the MCQ says breast present but uterus is absent. Now, we have only two differential diagnoses. So, one will be Mullerian agenesis, the other is androgen insensitivity syndrome, right? Now, please remember, in these cases, again, what helps you is ultrasound and testosterone levels. Why? Because here in ultrasound, you see an absent uterus and ovaries are present. So, we'll write it in the table below. But please remember, the main thing for confirming the diagnosis here will be karyotyping, right? So, finally, to differentiate Mullerian agenesis from AIS, the best test is going to be karyotyping. Now, these two are very often asked in your exam, so you should know everything here. In Mullerian agenesis, usually it is an absent vagina, whereas here it is a blind ending vagina. Do you know what is the other name for Mullerian agenesis? Yes, it is MRKH syndrome or Rokitansky syndrome. And what is the other name for AIS? Yes, TFS, testicular feminization syndrome. Okay, so testicular feminization syndrome, that's the other name. Now, what about pubic and axillary hair? Here they are absolutely normal. Here they may be absent. Sometimes to confuse you, they may write the word sparse. Okay. Breast development is present in both. Here the gonad is ovary, while in AIS it is going to be the testes. Uterus is absent in both. Okay. The reason for absent uterus here is because the testes is producing Mullerian inhibiting substance. Testosterone levels here are female level hormones, while here they are raised, they are male level hormones. The karyotype for Mullerian agenesis is XX, while here it is XY. Please remember, gonadectomy is done in AIS, not done in Mullerian agenesis, and this is typically done after puberty. Right? I want you all to remember that TFS or AIS is the most common cause of male pseudo-hermaphrodite. Okay, it is the most common cause of male pseudo-hermaphrodite. What is the most common cause of female pseudo-hermaphrodite? Congenital adrenal hyperplasia, right? So, CAH for female pseudo-hermaphrodite. Okay. So, remember these, your NEET PG does tend to ask. Okay, somebody was asking me Riefenstein. What is Riefenstein? Riefenstein is partial AIS. Okay, so Riefenstein syndrome is partial AIS, where some receptors are sensitive. Okay. Now, suppose the MCQ says breast development is absent, and then they ask you next step. So, if they are saying breast development is absent, what is the next step? Then you should answer it as FSH levels. That is the best answer because you suspect the problem to be either at the higher center or at the level of the ovary. And to differentiate, you need FSH. So if the FSH level is high, you are going to suspect Turner syndrome. Whereas if FSH level is low, you are going to suspect Kallman syndrome. Yes, Riefenstein beta, Riefenstein, लिखा मैंने ऊपर. Partial AIS is Riefenstein. Okay. Now, important things which I think you already know. Here it is 45XO, Kallman's is 46XX. Turner के लिए they will say short stature. Here it is normal height. Turner syndrome, please remember when we say they have streak gonads. Here it is going to be normal ovary. The classic finding here is anosmia, which is not seen with Turner syndrome. In Turner's, the classic findings are short stature but shield chest, right? Low posterior hairline. Okay. So shield shaped chest, low posterior hairline, right? These are characteristic to Turner syndrome, right? Also, please remember they have certain immunological problems like diabetes, like Hashimoto's. They also have problems with respect to hearing losses. So both SNHL as well as conductive losses there. They have hypertension and cardiovascular abnormalities as well. So those are all associated with Turner syndrome. You should use them as keyword. Yes, webbed neck as well. So these are just some words that you should know. But all I want you to remember here is there is going to be normal IQ and slightly short lifespan and no bar body. Okay? No bar body. Is that clear to everyone? Okay, so please remember these things. And when it comes to Kallman's, you can give them injection GnRH or you can give them injection gonadotropins. Remember, if you're giving GnRH in Kallman's, it has to be pulsatile. Okay, it has to be pulsatile. Is that clear, bacha? Okay, perfect. Please remember, Swires is not very important for NEET PG, but this is a pure gonadal dysgenesis. Okay, so this is pure gonadal dysgenesis. And here also there are streak ovaries, female phenotype. So they are very much like Turner's. So streak ovaries, female phenotype and normal stature. Okay. The karyotype is the key thing here. This is 46XY. And because they have a Y chromosome, they need to undergo gonadectomy, which is not done usually for Turner syndrome. Is that clear, bacha? Okay. Chalo. आगे बढ़ते हैं. Secondary amenorrhea is absence of menses for how long? Absence of menses for, yes, for a span of 3 months or 90 days. Please remember, only and only if they say irregular cycles, then the answer becomes 6 months. But otherwise, the answer will remain as 3 months. Is that clear? Now, what is the first step? Always you have to rule out pregnancy. That's the most important thing. Now, if UPT or HCG is negative, then you will do 3 important hormones, right? Which ones? We do FSH, TSH and prolactin. These are must-dos. You can add some more like testosterone and LH, but these are must-dos. Now, let's look at this. If your patient has elevated prolactin, what could be the other reason for this? So, this could be high levels of TRH, thyrotropin releasing hormone, right? So, you have to treat both first or you should treat thyroid dysfunction first. So, if both are abnormal, please remember, treat thyroid dysfunction first. Okay? So treat thyroid dysfunction first. What is the drug of choice for high prolactin levels? It is cabergoline, right? So remember, it is cabergoline, dopamine agonist. Now, if the levels of FSH are high, where do you suspect the problem to be? So high FSH, I think the problem is going to be at the level of gonads. So premature ovarian failure, which is also called as premature menopause. Now the name is POI, okay? Primary ovarian insufficiency. And who is going to tell me if the FSH levels are normal? What are you going to suspect? Then we will suspect PCOS as well as Asherman's, right? So then we will suspect PCOS as well as Asherman's. Is that clear to everyone? Perfect. Now we'll talk about PCOS and Asherman's separately, so I'm not putting it here. Quickly, let's look at puberty. The first sign of puberty is, please remember, it is growth spurt. Okay, but if we ask you the first visible sign, then it is thelarch, which corresponds to Tanner stage 2. So anything written as 2 or more means thelarch has happened. Okay, Tanner 1 is prepubertal. Okay, it's prepubertal. Now, please remember, when we talk about precocious puberty for females, it is if they develop secondary sexual characters before 8 years. What is the cutoff for boys? 9 years. So cutoff for boys is 9 years. Okay. What is, remember, the most common cause of precocious puberty is idiopathic, also called as central, which means there is just premature activation of the HP axis. Is that clear? When we say it is central or idiopathic, what is the drug of choice? It has to be GnRH agonist. But how will we give it? Jaldi batao? Yes, very good. It is going to be now continuous, not pulsatile. ठीक है बच्चा? Perfect. Now, when we talk about most of the times in the central, there is no underlying pathology, but sometimes there can be a brain tumor. And if we ask you which brain tumor is linked to precocious puberty, it is a hypothalamic hamartoma, right? Also, can you tell me here, the other places where we use continuous GnRH agonists? So one is precocious puberty. Where else do we use it? So we also use it for fibroid uterus. We also use it for endometriosis. We can also use it for hirsutism, abnormal bleeding, and 2 cancers, breast cancer and, yes, prostate cancer. So these are the other places where we can use them in a continuous manner. It is important. ठीक है? आगे बढ़ते हैं. Now, when we talk about peripheral precocious puberty, it is called as GnRH independent. Okay. Now, here some of the important causes are McCune-Albright, granulosa cell tumors, but you should also remember that it can be adrenal tumors. It can be also a congenital adrenal hyperplasia. It can also be what? Severe prolonged hypothyroidism. Yes. So severe prolonged hypothyroidism. They're all causes of peripheral precocious puberty. Is that clear to everyone? Koi baat nahi, Shreya. You try and answer here. I am also writing bache every single word. ठीक है? So you try and write. अगर कुछ रह जाता है, you can always fill it up later. But I want you to speak it out. Okay? So you have to speak out the answers. You have to ensure that you are knowing the keywords. That's the game. If you understand, see, what are these fill in the blanks? They're nothing but keywords. You have to strike these keywords in the exam. The more you're able to do it, the better it gets. Okay? Is that clear? No, don't worry. As I said, the entire video will be uploaded. The entire annotated PDF will be uploaded for you. Okay? So, we are already, the session was planned until 2. We are already going beyond. So, which means I am doing it slower. Right? Some sections I'll do slow. Some we need to go fast because this is a revision. It's not where we are going to, go to exactly explanation of everything. Okay? चले करें आगे. Everybody ready? साथ साथ कुछ खा लो आप लोग. If you want to eat something, eat a biscuit, eat chocolate, eat something. We'll give you a break after the session. Okay? So Abhi, go on. How's the Josh? Everybody, are you going to give the answers in the chat box? Yes? See, the idea is to consolidate and concise everything for you so that you don't have to do anything else. And as I said, this is what you have to do after DVT. Just revise the booklet as many times as you can and it will have a super high hit rate. Right? So this is what is going to be most productive for you. If you are hungry, as I said, we'll give you a break after my session. But till then, have a chocolate, have a biscuit. Okay? Take some little snacks with you. Okay? Chalo. So now, please remember when we talk about hirsutism, it is about male pattern hair growth. Right? Now, when we talk about male pattern hair growth, you have to know it is under the influence of androgens. It's not under the influence of estrogen. Androgen में भी बेटा कौन सा androgen होता है? Dihydrotestosterone. And I told you testosterone converts into DHT with 5-alpha reductase. Yes? Now, if we ask you what is the main source of testosterone in females, what is it? What is it? The answer is peripheral conversion. Okay? So main source of testosterone is peripheral conversion, but yes, ovary will also produce androgens, right? Now the important one is which androgen is not produced. So remember, dihydrotestosterone and DHEAS, okay? DHEAS, this is not produced by the ovary. What is the scoring system we use? So Ferryman, Galway. And we know, we said if it is more than 8, if the Ferryman-Galway score is more than 8, then we say there is hirsutism. Okay? Can you tell me which is the screening test for congenital adrenal hyperplasia? So it is 17-hydroxyprogesterone. The levels will be more than 200. Okay? Please remember DHEAS is not coming from the ovary. It only and only comes from the adrenal gland. So it is a marker of adrenal gland tumor. Okay? Okay. Now, please remember in PCOS, the levels of testosterone are minimally raised or mildly raised. So they have to be less than 150 nanograms per deciliter. Okay? If the levels are more than 150, then you should think of ovarian tumor. Not just more levels, right? If the levels are or if the symptoms are showing you symptoms of virilization, that is also a marker of a tumor. For example, clitoromegaly. So clitoromegaly is never seen in PCOS. It is seen in virilization. Okay, is that clear to everyone? Okay, so what is the drug of choice for hirsutism? It is going to be combined oral contraceptive pills. You give OCPs for 6 months. If the response is poor, then you can add spironolactone, right? So then you can add spironolactone. Please remember, hirsutism can also be caused by, as I said, androgen producing tumors. For example, you all know sertoli-Leydig, but I am sure some of you really do not know that sertoli-Leydig tumor is also called as arhenoblastoma, and it was earlier also called as androblastoma. Okay, so androblastoma, arhenoblastoma, they are names of, yes, so they are all names of sertoli-Leydig cell tumor. Is that clear? Yes, the Telegram quiz is really high yielding. Chalo, PCOS karte hain. So now we need oligomenorrhea and amenorrhea as one of the criterias in PCOS. Can you tell me what is the reason here? The reason is anovulation. Hai na? Now, please remember as per the Rotterdam criteria. So we are specifying, right? So as per the Rotterdam criteria, ultrasound pe we should see 12 or more follicles and the ovarian volume should be more than 10 cc. Okay, the ovarian volume has to be more than 10 cc. Suraj, then you have to give the answers. See, if you are not going to give answers, then you will lose your focus. So your idea should be to commit your answer in the chat box. Everyone, are you going to commit your answer? Because you have to ensure that you are revising here with me, right? So everyone has to commit an answer, and that is a must do thing. Okay. So once you have ruled out pregnancy, because the lady is going to come with amenorrhea, and as we said, it is going to be secondary amenorrhea. So you rule out pregnancy and then you have to do FSH, TSH, prolactin. But in a patient where you suspect PCOS, which means there was hirsutism, right? Then what do you have to do? Can you tell me what will you add? Yes, then you have to add testosterone. So if you see features of hirsutism with amenorrhea, then the best answer becomes testosterone. Is that clear to everyone? Yes, are you with me? Are you with me, everyone? Okay, which hormone levels are elevated? LH. So LH levels are elevated. Which estrogen is elevated? Everybody needs to answer. I need to see the answer. I need to see the answer. Yes, it is going to be E1. E1 kahan banta hai? Adipose tissue. Right? So this is made in the adipose tissue from androgens. So LH is raised, E1 is raised, FSH is normal, E2 is normal. Perfect. अब बात बनी ना, ऐसे ही fire करना है आंसर सबने. Okay? What about SHBG? They are reduced because of negative feedback from androgens and insulin. Right? So SHBG is low. चलो, drug of choice कौन बताएगा? Combined oral contraceptive pill. But anytime they ask you first advice in a obese patient, then it has to be weight loss and lifestyle modification. Yes, very good. So weight loss and lifestyle modification. 5 to 10% weight loss. Perfect. Very good. चलो, अगर लिखा है drug of choice for hirsutism in PCOS, then the answer remains as OCPs. I have told you, first OCPs for 6 months and then you are going to add spironolactone. Is that clear? If they ask you drug of choice for infertility in PCOS, then the single best answer now is letrozole, followed by clomiphene citrate. If the woman wants to conceive, never give spironolactone, right? So never give spironolactone if she wants to conceive. Good to go? Perfect. Very good. Very good. Keep it up. Let's go forward. Menopause is defined as 12 months or 1 year of amenorrhea, right? Now please remember, what is the average age? You people get confused. In the textbooks, it's written as 51 years and that is what we are going to mark. Okay? We are not writing in India, in USA. The general answer is 51 years. Please remember, perimenopause कब शुरू होता है? Around 4 years earlier. So perimenopause will happen around 47 years. It can happen, see, menopause can happen anytime after 45 years, right? So after 45, any time it can be menopause. Between to 40-45, it is called as early menopause. And at less than 40, it is called as premature ovarian failure. Is that clear to everyone? Yes. Now quickly tell me, what is the cause of lack of symptoms are because of? This is because of lack of E2. And whenever we ask you most common symptom, it has to be answered as hot flashes. Certainly leading का ट्यूमर का नाम है अर्हीनोब्लास्टोमा या एंड्रोब्लास्टोमा. अर्हीनो, ARRHENO, अर्हीनोब्लास्टोमा. Okay. As I said, premature menopause is less than 47 years. Usually FSH levels will be more than or equal to 40. Anything more than 25 is also suggestive of ovarian failure. Okay, is that clear to everyone? Okay, now please remember, as I said, most common symptom has to be answered as hot flashes. Okay, hot flashes. Is that clear? Okay, now what are the only two conditions for which we give HRT? So remember, we are going to give HRT for either hot flashes or we can give it for vaginal atrophy. Right? So, or we can give it for vaginal atrophy. Now, if the uterus is intact, we have to give E plus P for hot flashes. Right? And if she is post-hysterectomy, who's going to tell me what is the answer? Only estrogen. Then it is going to be only estrogen. If you are giving it for hot flashes, then the route is what? Yes, it has to be systemic. And mostly it is transdermal. So this is for hot flash. Perfect. Can you tell me what will be the route for vaginal atrophy? Local. In the form of estrogen cream. This is what you do for atrophy. Right? So for atrophy, never give systemic therapy. Is that clear to everyone? Yes? Only topical or local. Yes. Excellent. Okay. Please remember, in general, contraindications of HRT are contraindications of estrogen. So anytime there is a breast cancer, endometrial cancer, liver disease, thrombosis, bleeding, we don't give estrogens. Is that clear? Now, confuser, what do you do for post-menopausal osteoporosis? Yes, so this is going to be bisphosphonates. Thank you so much, Varun, and someone else also wrote it. Thank you for reminding me. Okay. Now, because some of you keep getting confused, what are the benefits and what are the harms? So I have given it for you, right? So please remember, estrogen and progesterone, when given together, they increase the risk of breast cancer. E alone will increase risk of what? Endometrial cancer, right? So E alone will increase the risk of endometrial cancer. Please remember, venous thromboembolism risk is specifically high with estrogen therapy. Is that clear? Okay. So remember these, and please remember, HRT is only going to be given if woman is less than 60 years. We will not give HRT to someone who is more than 60 years of age. Is that clear? Yes? Okay. Now, let's move on to infertility. So, if your patient is less than 35 years, when do you begin evaluation? Come on quickly. Vedant, give me the answer. So, less than 35, intercourse for 1 year. That's when you begin evaluation. And if she is more than 35, you begin evaluation at? Yes, 6 months of unprotected intercourse. If the patient is beyond 40 years, then we will wait only, you don't even need to wait for 6 months. Then you can begin evaluation at less than 6 months also. Okay. So it is all dependent on age of the patient. Is that clear? Okay. Now, can you tell me what is the most common cause of male factor infertility? So some of you think it is idiopathic or unexplained. It is incorrect. So it is primary hypogonadism. Do you know what it means? Defective spermatogenesis. Okay. This means defective spermatogenesis. So in these patients, the semen analysis is going to be abnormal because the problem is in the testes. Okay. Now, when you talk about semen analysis, abstinence ka minimum requirement kya hai? Minimum requirement is 2 days. That's the best answer. The range is 2 to 7 days. Okay, bacha? Now, it has to be examined within 1 hour. So the best mode of the sample is masturbation. It should be examined within 1 hour. Is that clear? Perfect. Good to go. Good to go, everyone. Yes. Are you ready for the answers? Okay. Let's do this now. So we are not going to fill it up. I have just given you the old and the new values for semen analysis. They are important. Very often asked as direct MCQs. You will just tell me what is asthenospermia. So this is reduced motility. Okay, it is reduced motility. Azoospermia, no sperms in the ejaculate. Don't confuse with aspermia. What is aspermia? Aspermia is no ejaculate. Okay, no ejaculate. Please remember, the most important parameter in semen analysis is morphology, right? So most important parameter is morphology. Is that clear to everyone? Okay. Then what is the best test to differentiate between obstructive and non-obstructive? The single best answer is serum FSH, right? But you could do the other hormones as well. So in obstructive, all hormones are normal. So FSH, LH, as well as testosterone, right? So please remember that all hormones will be normal. Okay? Now, put it very simply, the management. If the count is less than 15 million, but more than 10 million, then we will do intrauterine insemination. Then we will do IUI. Who is going to tell me the next answer? If the count is less than 10, jaldi se batao, what are we going to do? Less than 10, IVF. Yes, perfect. Less than 5, ICSI. Right? So we do a TC, testicular sperm extraction. And then with these sperms, we do a ICSI. What is ICSI? Intracytoplasmic sperm injection. Okay? Chalo. Ready everyone with the ovulation disorders? Alright. So this is WHO classification of ovulation disorders. Group 1 is hypogonadotropic, which means the defect is in the higher centers. So the FSH levels are going to be low. A typical example is Kalman, right? So the typical example is Kalman. Group 2 is where PCOS comes. That is what is important. And this is normogonadotropic, which means FSH levels are going to be normal. And it is also normoestrogenic. So please remember, PCOS is WHO group 2. What comes in group 3? Yes, premature ovarian failure. Okay, group 3 is premature ovarian failure. So here the FSH levels are going to be high. No feedback inhibition, so high FSH levels. Now, coming to tests of ovarian reserve, these are very, very important for your exams. Quickly tell me when or what is the best time to do serum FSH. So the best time to do serum FSH is day 3. Normal value less than 10 international units. Usually any place between 4 to 10 is generally considered as normal values. Okay? What about AMH? It is done on any day. Okay, it is done on any day. Please remember, it is the best test of ovarian reserve as it shows no fluctuations. Also with respect to AMH, please remember it is a glycoprotein hormone, and remember it comes from preantral and small antral follicles. Okay, now value less than 0.5 nanograms is poor reserve. 1 to 3 is usually the normal value. So 1 to 3 nanograms is usually the normal value, but less than 0.5 is poor reserve. Less than 1 is borderline. Okay. Now, quickly tell me antral follicle count कब करते हैं? Day 2 to day 3. It is an ultrasound based test. Okay. Then other tests of ovarian reserve are inhibin B and clomiphene citrate challenge test. Just know the names, don't go into too many details. But remember that these are all tests of ovarian reserve. Please remember, serum progesterone is not a test of ovarian reserve at all. It is a test of ovulation. Is that clear to everyone? Yes? Good to go? Okay. Let's quickly look at tubal factor infertility. This we have already covered. IOC for this is HSG. What is the gold standard evaluation? Laparoscopy. Right? And we said we will do laparoscopy chromoperturbation. Okay? Okay. What are we going to do? If HSG shows bilateral hydrosalpinx, we'll do a lap. Right? Once you confirm that that is hydrosalpinx, what are you going to do? For hydrosalpinx, it has to be IVF. Is that clear? Straight away, IVF. But please remember, salpingectomy. Okay? Salpingectomy. What will it do? It improves IVF outcome. So, if they ask you what procedure will improve the outcome, it is salpingectomy. These days we can also do tubal clipping, right? So tubal clipping or salpingectomy. The fluid should not enter the uterine cavity. Is that clear to everyone? Now, please remember, if there is a bilateral proximal obstruction, cornual block, and we ask you next step, then it has to be laparoscopy plus hysteroscopy. But if we ask you best step, okay, then it is going to be IVF even for proximal disease, right? So even for proximal disease, it has to be, the best is IVF. Who is going to tell me what do we do in hysteroscopy here? Cannulation. Yes, so in hysteroscopy, we will do cannulation. Is that clear, bacha? Chalo. Quickly, a few things about genital TB. Route of spread is hematogenous, right? So the route of spread is hematogenous. Okay. What is the most common site? Ampulla. Followed by isthmus. Followed by isthmus. Now, once we know that the most common site is tube, if they ask us how does it reach the uterus, if they're asking you the route for uterus, it has to be direct spread. Okay. Now, please remember, has been a PYQ, vulva and vagina, right, is the least common site. Okay. Now, clinical presentations are important here because I have seen multiple times NEET PG ask questions on, genital TB. So, initial symptoms, please remember, are going to be infertility. Okay. Followed by pain. So, most common symptom is infertility, then comes pain, and then comes menstrual irregularity. Now, a lot of times you ask me, within menstrual irregularity, what are you going to see? So, who is going to tell me what is the most common one? The most common is amenorrhea. Okay, amenorrhea. Followed by oligomenorrhea. So, amenorrhea followed by oligomenorrhea. Is that clear? What is the most common finding? If you do a PV exam, normal pelvis, right? It will be a normal pelvis. Now, when we talk about diagnosis of TB, what do you need? Endometrial biopsy. What else can we do? We can do menstrual blood for PCR analysis. Right? So, menstrual blood for PCR analysis, remember it has to be a day 1 sample, right? It has to be a day 1 sample. Clear? Alright. Now, in case there is genital TB and there are severely damaged tubes, then what should be the answer? The answer should be IVF. we will give ATT, but as far as infertility is concerned, we will have to do IVF. Yes, everyone? Great. I can see most of you are committing your answers, but I want everyone to commit your answers. Don't worry if some point is missed. I told you the entire annotated PDF, the entire video will be uploaded for you, right? So please be with me. Try and answer as much as you can in the class. Let this class itself be a revision for you, right? So that when you go back and put the missed things, it is like a second revision. So this itself will be your first revision. Yes, everyone with me? Okay. Chalo. Now we are going to talk about some uterine problems. Okay. Which fibroid is associated with infertility? Only and only submucosal. Okay, so only and only submucosal. Now, please remember, if there is infertility, okay, and although the fibroid is asymptomatic, still you are going to do a hysteroscopic myomectomy. This is the only place that we are treating asymptomatic fibroids. Generally, we say asymptomatic, no treatment. Okay, but if she has come to us with infertility and she has a submucosal fibroid, we will do a hysteroscopic myomectomy. Now, again, submucosal fibroids can cause heavy bleeding. The treatment of choice for this heavy bleeding due to submucosal fibroids is again hysteroscopic myomectomy. That is the treatment of choice. Don't go and write OCPs, right? So if it is treatment of choice, it is a myomectomy for submucosal fibroids. What are you going to do if there are intramural fibroids? They are causing bilateral block, and this is why the woman has infertility. What are you going to do? So now you will again have to do a myomectomy, preferably a laparoscopic. Otherwise, as I said, asymptomatic fibroids, no treatment. So these are exceptions. Okay. So in general, no treatment. What about perimenopausal women and asymptomatic fibroid? Then what are you going to do? Then what are you going to do? Nothing. Okay, perimenopausal women, asymptomatic fibroid, nothing, no treatment, irrespective of the size. Is that clear to everyone? So as long as it is asymptomatic, no treatment. Okay? Now, please remember, when you talk about endometrial polyps, the typical age group, okay, typical age group is perimenopausal and postmenopausal. So relatively older women. They will typically cause irregular bleeding. See, fibroids cause regular and heavy bleeding. These will cause irregular bleeding, right? What is the characteristic sign on ultrasound? Feeder vessel. So we will see a feeder vessel sign. Yes. What is the treatment of choice? Again, hysteroscopic polypectomy. Can you tell me one drug which has been linked to polyps? So, tamoxifen. Please remember, tamoxifen increases risk of polyps. Remember this. They will give it to you. Okay? Now, coming to Asherman syndrome. So, if your patient has amenorrhea and intrauterine adhesions, yes, please remember, what are we going to do for them? So, once there are intrauterine adhesions, the treatment of choice is hysteroscopic adhesiolysis, right? So, it is hysteroscopic adhesiolysis. That is the treatment of choice. Is that clear? If we ask you highest risk for Asherman's, highest is curettage done for PPH. Right? Multiple curettage is a risk factor, but PPH के लिए और भी ज़्यादा. What is the most common presentation? The most common presentation is menstrual irregularity. Okay, it is menstrual irregularity. But if I ask you within menstrual irregularity, then it is amenorrhea followed by what? Hypomenorrhea. Okay. So amenorrhea followed by hypomenorrhea. Bache. Good to go? Yes? Okay. What are the other complaints? Infertility, dysmenorrhea and recurrent pregnancy loss. So yes, they can cause cyclical pain also. Right? Now, LH, FSH, estrogen levels, all hormone levels are going to be normal. What about pregnancy? Quickly tell me. If I talk about pregnancy, what about LH, FSH levels? Because pregnancy can be a DD. Here the LH and FSH levels are suppressed, very low levels. In Asherman's, they are going to be normal level. Is that clear? Perfect. Most common symptom of endometriosis. What is the answer? Pain. And which pain? Dysmenorrhea. Okay. So it is going to be dysmenorrhea. Okay. But any time you see words like dyspareunia with adnexal mass, you should think of endometriosis. So if you see all the three things together, pain, adnexal mass, infertility, think of endometriosis, right? What is the most common site? Ovary, right? So the most common site is ovary. What is the most common theory? Retrograde menses. So whenever there is obstruction, the risk of endometriosis will increase. What is the name of this theory? Sampson's. Okay. It is Sampson's theory. Investigation of choice. Very rarely we tell you it is laparoscopy. Who is going to tell me what are the key named signs in laparoscopy? So one is called as powder burnt areas. Okay. The other is called as red flame lesions. Okay. Red flamed lesions. Alright. Please remember, anytime you see infertility or pain and retroverted fixed uterus, this is also which points towards endometriosis, right? So this is a PV finding. Retroverted fixed uterus goes in favor of endometriosis. Yes? Okay, perfect. Yes, chocolate cyst is something that we see on the ultrasound itself. We were specially talking about laparoscopy, right? Okay, so if it is mild endometriosis and infertility, what do? Clomiphene citrate and IUI for 3 months, right? But if it is moderate to severe endometriosis and infertility, what is the answer? IVF. Then straight away the answer is IVF. Please remember, I'm talking about chocolate cyst now. Whenever we talk about ovarian endometriomas, right, if they are asymptomatic and less than 5 centimeters, then they only need follow-up with ultrasound. Okay. In case they become symptomatic or they are bigger, then you will do a cystectomy. Okay, then you will do a cystectomy. Alright, my question to everyone. Are you going to answer? IUI is intrauterine insemination. Let's see who is going to answer first. Come on, tell me. Are you going to routinely remove chocolate cyst before IVF? Yes or no? Are you going to routinely remove the chocolate cyst before IVF? So the answer is no. Routine removal is not to be done before IVF. As long as they're asymptomatic, don't remove them. Is that clear? Perfect. Good, good, good. Okay. What are the key findings in adenomyosis? There is going to be heavy bleeding. And there is going to be dysmenorrhea. Right? So heavy menstrual bleeding and dysmenorrhea is what you see with adenomyosis. Investigation of choice. So please remember, generally the first investigation is ultrasound and IOC we say is MRI, right? What is the way to confirm diagnosis? Histopath, okay? The way to confirm is histopathology. Is that clear to everyone? Okay. This histopath is not endometrial biopsy. So please remember, endometrial biopsy cannot diagnose adenomyosis. Okay. We are doing it to rule out other causes of abnormal bleeding like hyperplasia, like cancer, but it is not done for diagnosis of adenomyosis. Is that clear to everyone? Good. Okay. What is the classic characterization of the uterus? It is a bogey uterus, soft. Okay. We use the terms like globular, it is enlarged, and it is tender. Okay. So please see the keywords: bogey, soft, globular, enlarged, tender. Okay. But I want you to remember, it does not go beyond 12 weeks size, right? So the maximum size that you can see with adenomyosis is 12 weeks. Is that clear? Okay. Treatment of choice. So in general, we put it as hysterectomy. But if we ask you first line, the first line treatment is symptomatic. You give it to reduce the symptoms. Okay. So then it can be OCPs, it can be Mirena, it can be Tranexa. Is that clear? Yes. Okay. Ultrasound signs are important. They are named signs, right? So one is Venetian blind. This is something that I want you to know. Myometrial cyst, then heterogeneous myometrium. This heterogeneous myometrium is also called as salt pepper. Important hai, PYQ hai, neet PG. Are you with me everyone? Yes. So remember these findings: Venetian blind, myometrial cyst, heterogeneous myometrium, and poorly defined junctional zone are features of adenomyosis. Good to go? Okay, perfect. Now, when we talk about Mullerian anomalies, what other thing is associated with it? Urinary tract anomalies. Yes? So, urinary tract anomalies. Okay. IOC is 3D ultrasound. Gold standard is MRI. Best procedure is laparo plus hysteroscopy. Best procedure is lap plus hystero. Suppose you have to mark only one of them, then the answer will be laparoscopy. Okay, laparoscopy would be the single best answer if you have lap in one option and hystero in the other option. Okay. Now, when we talk about didelphius, there is complete failure of fusion of the Mullerian ducts. Okay, complete failure of fusion of Mullerian ducts. Please remember, majority of times didelphius, will have 2 uterine horns, 2 cervix, 1 vagina. But sometimes there can be 2 vagina because they are associated with what? Vaginal septum. So if they ask you most common anomaly to be associated with septum of the vagina, the answer is didelphius. Remember, it has the best reproductive outcome and you cannot see transverse lie in it. Okay. Transverse lie is not possible here. Is that clear? Okay. Perfect. Biconuvate. Biconuvate will result from partial fusion. Okay. So some part fuses and some doesn't fuse. Now please remember, very often, okay, you are going to get images of HSG. All you have to see if the angle between the 2 horns looks wide, right? If the horns look far apart, the degrees you cannot count or measure there. So you just see if it looks wide, you answer it as biconuvate. If it looks narrow, you answer it as septate uterus. It is as simple as that. All right. Please remember, in a septate uterus, the external shape of the uterus is going to be normal. So normal fundus. Okay. So the fundus is going to be absolutely normal. What about biconuvate? It has a dipping fundus. Okay. It has a dipping fundus. All right. Septate, please remember, is the most common Mullerian anomaly. The angle between the two horns is going to be acute. Yes, the angle is going to be acute. What are the pregnancy complications? Recurrent pregnancy losses. Yes, more characteristic in the second trimester. Yes, it can cause first trimester as well, but second trimester loss is more common than first trimester. Good to go, everyone. Important hai ye, important hai. What is the treatment of choice? Because it has a poor reproductive outcome, we want to operate. What are we going to do? Okay, what are we going to do? It is going to be hysteroscopic resection of the septum or septoplasty. Please remember, hysteroscopic is also put as transcervical, right? So don't get confused if they write transcervical, it means the same thing. Yes? Okay, DES we've already done, T-shaped uterus and clear cell cancer of the vagina. What does it do in the male baby? Hypospadias, right? So in the male baby, it is going to do hypospadias. Don't worry, we'll take lunch at 3 o'clock, right? We'll be, okay. We'll be free in some time, maybe just probably 15-20 minutes more, and then we'll give you the lunch break, okay? Sit tight, we're almost able to do this. We'll do the session of images after that. Okay? Chalo. Okay, quickly tell me, what are the most common HPV types to be associated with pre-malignant lesions? ये तो आसान वाला है, जल्दी बताओ. 16 and 18, right? And 6 and 11 will cause condylomata acuminata, alright? Time का पता ही नहीं चला, आपको पता चला, I didn't know when it was 3. I thought अभी 3 नहीं होंगे, but anyways. The most common site is transformation zone. Agar transformation zone is not in the options, then you are going to mark squamocolumnar junction, right? So then you're going to mark squamocolumnar junction. Is that clear? Okay, quickly. Now when we talk about Gardasil 9, the age group is 9 to 26, but target age as per WHO now is 9 to 14 years, right? So you want to give it in the younger age group, okay? Now, vaccine is made from which particles? I hope you all remember this. Do you remember? We did it in the PYTs as well. L1 capsid protein. 9 types, 16, 18, 6, 11. Apart from that, what are the other strains? 31, 33, 45, 52 and 58. Yes, those are the strains and it's better you know them. If the woman is less than 21 years of age, she will get 1 or 2 doses, right? But if she is beyond 21 years, then she will receive 2 doses 6 months apart, right? So then she will receive 2 doses 6 months apart. Do we need to do screening after the vaccine? Yes, screening has to be continued. Vaccine is not recommended in pregnancy, right? We've already done that. It is not recommended in pregnancy. Chalo, quickly. What is the best screening test? HPV DNA test followed by VIA. Okay. Can you tell me which is most cost-effective screening method? Which is the most cost-effective screening method? Then the answer will change to VIA, okay? Now, as per WHO, so we are answering only as per WHO. Please remember, start screening at 30 years, stop at 50 years. The protocol is screen and treat or screen, triage and treat. What is the interval between HPV testing? Batao? Yes, 5 years. Minimum requirement is 5 years. What about VIA and PAPS? 3 years. Yes. Treatment of choice in general should be answered as LEAP. Okay. Treatment of choice in general should be answered as LEAP. Okay. Chalo. Now, in resource-rich countries, yes, we can start as early as 21 years, but this should be only with pap smears. Okay. After 25 years, we can do the HPV DNA test. So these are international guidelines. Okay, these are for resource rich countries. Now please remember, nowadays you should know that HPV test can be used as a primary test if the country affords. It can be used. The interval remains the same. You should know what is a co-test. So co-test is, when you do PAPS and HPV together, right? So if you do PAPS and HPV together, it's called as co-test. And for that also, the interval will be 5 years, right? For that also, the interval will be 5 years. Okay? Yes, VIA is visual inspection with acetic acid. So international guidelines, we don't need to know in too many details, but yes, WHO guidelines, you should know. Okay? Chalo. Most common symptom is irregular bleeding. Okay? Irregular bleeding. Okay? What is most specific? Post-coital. Okay? But please remember, when we say post-coital and they say next step, the answer should be per speculum examination and PAPS. So per speculum examination and PAPS. But I told you, in case they say abnormal looking cervix, tab batao kya answer karoge jaldi? Everyone focus on me, not on anyone else. Quickly tell me. If they say postcoital and abnormal cervix, then it has to be a biopsy. Okay, then it has to be a biopsy. Okay, most common site, transformation zone. Okay, which means ectocervix. Okay, here I already told you it has to be a biopsy. It can be a 4-quadrant biopsy. It can be a punch biopsy. Most common cause of death, they are neet, PG, PYQs, so uremia. Hydronephrosis, you don't need to remember the entire stage, but please remember hydronephrosis is stage 3. Sentinel lymph node are paracervical group of lymph nodes. Okay, paracervical group of lymph nodes. Alright. What is the most common cause of postmenopausal bleeding? It is endometrial atrophy. Okay, so it is endometrial atrophy, but please remember polyp is also an important and emerging cause of postmenopausal bleeding. Is that clear? Endometrial cancer again is going to cause irregular bleeding. Okay, it is going to cause irregular bleeding. Now, the first thing when a patient comes to us with postmenopausal bleeding, which is the most specific complaint, we will do a transvaginal ultrasound. Yes, quickly tell me, what is the cutoff here that we use? More than 4 mm. So if the thickness is more than 4 mm, we must do a biopsy. Okay, so investigation of choice is endometrial biopsy, right? But in case there is a focal lesion, then what are you going to do? Hysteroscopy. Okay, then you will do a hysteroscopy. Quickly, which drug has high risk? Tamoxifen. So then you should do endometrial sampling. Which ovarian cancer increases risk of endometrial? Granulosa cell. Because it is a estrogen producing cancer. Syndromes which increase the risk. So one is Cowden syndrome. The other is HNPCC. The third is PCOS, right? So these syndromes increase the risk of endometrial cancer, right? Please remember, obesity is a risk factor. Hypertension and diabetes are also risk factor. Nulliparity and infertility are risk factors. So these are other risk factors that you should know. Can you tell me what is protective? Very important. Oral contraceptive pills, smoking, okay, multiparity, breastfeeding, right? So these are going to be protective. Is that clear to everyone? These are going to be protective. Okay? Alright, we're almost there and then you get a little break. So we're almost done. Stay with me here and then we will take a break. Chalo. Gene associated with type 1 cancer, P10. Type 2 cancer, P53. Type 2 have poor prognosis, right? Type 2 cancers have poor prognosis. Okay. Which type of endometrial cancer has the highest risk or worst prognosis? Tell me, worst. Worst is with clear cell. Okay. So worst prognosis is with clear cell cancer. Okay. Good to go. Chalo batao. Treatment of choice कौन बताएगा? Hyperplasia with atypia. Hysterectomy. Okay. With atypia is hysterectomy. And if your patient is postmenopausal, also do what? BSO. Bilateral salpingo-oophorectomy. Are you with me? Okay. Without atypia, Mirena. Preferred over MPA, medroxyprogesterone acetate. Staging for endometrial cancer, please remember, is surgical. There is no need to learn the staging. Okay, there is no need to learn the staging, everyone. Okay, chalo. Going on to ovarian masses. Now, when we talk about most common cyst of the ovary, remember it is a follicular cyst. Okay, so remember it is a follicular cyst and it is a benign cyst. So what are you going to do with the follicular cyst? Just wait and watch. You repeat ultrasound at 2 to 3 months if required, right? And most of these cysts are going to disappear on their own. So you don't really need to do anything. MPA is bache medroxyprogesterone acetate. It's the name of the drug, oral drug. Right? So oral is MPA. Okay? Good to go, everyone? Have a biscuit. I'm sure you can. You people are not speaking. So you can have anything that you want. Have a biscuit, have a chocolate, and then we take a lunch break. Okay? Alright. Theca lutein cysts we have already seen. Please remember, they are associated with high levels of HCG. Why? Because alpha subunit is similar to alpha of LH and FSH. Yes? What is the condition they are associated with? I hope you remember. Complete mole. Typically, they are associated with complete mole. But in all the conditions where HCG is high, you can see these cysts. Okay? Now, what if these cysts persist after suction evacuation? We have seen that they indicate GTN, neoplasia, right? Can you tell me which neoplasia? Mostly they are seen with choriocarcinoma. They are not seen with invasive moles, okay? So they are usually seen with choriocarcinoma. Now, when you see an ovarian mass in a young girl, please remember, it could be suspicious of tumors. Which tumors? Germ cell. Okay. So it could be suspicious of germ cell tumors, which are typically seen in younger girls. Okay. Can you tell me, apart from germ cell tumors, which sex cord tumor can cause precocious puberty? Yes. So granulosa cell. Normally, granulosa cell are seen in older women, but in younger women, they can cause precocious puberty. Okay. Please remember, all germ cell tumors tend to be unilateral. Okay. They tend to be unilateral. Alright. Chalo. Please remember the key things when it comes to malignant features in the mass. So, if there are solid components, okay, if there are thick septae, if there are papillary excrescences, okay, if there is increased vascularity, ascites, and enlarged lymph nodes. If you don't see any of this, then it is a benign mass. So, benign masses are cystic, they are anechoic, and they are unilocular. Right? So, these are typical features of benign mass. So, if it's a benign mass, what are you going to do? As I said, simply repeat ultrasound at 2 to 3 months. Right? So, simply repeat ultrasound at 2 to 3 months. Is that clear to everyone? Yes? Okay. Great. Tumor markers we have done multiple times, so you should be able to give me very quickly. Serous का आंसर क्या है? CA125. Dysgerminoma, the main answer is LDH, but it also releases HCG and PLAP, does not secrete alpha fetoprotein. Yolk sac tumor, the main answer is alpha fetoprotein, but remember it also secretes LDH. Papillary excrescences, they mean growths, okay? So, papillary excrescences. Okay, what is the answer for choriocarcinoma? HCG. For mucinous, CEA, carcinoembryonic antigen. Granulosa cell tumors, inhibin. Remember, they also secrete estrogen, but the tumor marker is inhibin. Yes? Alright. This is super important, again, repeatedly coming in the exams. Now, classic histopath findings. Again, I have done it with you multiple times. So, you are going to give me quickly. Brenner's, what do you see in the Brenner's tumor? Voldard cell nest. Yes? So, Voldard cell nest. Serous tumors. What do you see? Samoma bodies. Yolk sac tumor. Schiller-Duval bodies. What is the other name for yolk sac? Yes. Endodermal sinus tumor. Dysgerminoma. What do you see? You see lobules with septae. And what is present in the septae? Lymphocytic infiltration. Yes? So, lymphocytic infiltration in the septae, right? Dermoid, rocky Tansky protuberance, right? So, dermoid में क्या मिलता है? Rocky Tansky protuberance. Krukenberg's. Signet ring cells. Yes, signet ring cells. Perfect. Granulosa tumors. What do you see here? Kohl-Exner bodies. Yes. Sertoli-Leydig. Rinke's crystals. Okay. And if you have to mark these are characteristic to Leydig cell tumor. Clear cell. Hobnail cell. Clear cell cancer में क्या मिलता है? Hobnail cell. Yes. Okay. Please remember the categories or what comes under what categories. The NEET PG people are specially fond of asking this. Okay. So, serous, mucinous, Brenner's, clear cell, they all come under epithelial category. Okay. Whereas dysgerminoma, teratoma, okay, choriocarcinoma, endodermal sinus tumor, they all come under germ cell category. Stromal and sex cord. So, granulosa cell, theca cell, fibroma. Right? They all come under the category of stromal. Now, please remember, fibroma is actually a stromal tumor. Right? Why is it popular? Because it is associated with what? Meigs syndrome. Right? So, it is a benign tumor associated with pleural effusion and pericardial effusion. Sorry, pleural effusion and yes, ascites. The pleural effusion is usually on the right side. Yes, so remember this. But I hope you remember what I said. Although the single best answer for Meigs is fibroma, but you have to know that Meigs can also be seen with granulosa cell, thecomas and Brenner's. Right? So this can also be seen with granulosa cell, thecoma and Brenner's. But as I said, the single best answer will be fibroma. Everything else is a pseudo-Meig. Okay, it is a pseudo-Meig. Okay. Dermoid cyst, please remember, is a mature teratoma. It has all three germ layers. Quickly, can you tell me the ultrasound signs of dermoid? Ultrasound signs. So, ultrasound signs may please remember Rocky Tansky. Remember the tip of iceberg sign. And remember the dot dash sign. they have been asked in previous exams, right? So dot dash sign. Yes, pleural effusion and ascites. Okay. Now this is actually the most common tumor in reproductive age as well as in pregnancy. Remember, dermoid has highest risk of torsion in pregnancy and it is seen in the second trimester. So highest risk of torsion is in the second trimester. Alright. Chalo. Please remember, staging for ovarian cancer is again what? It is surgical. Now important. Only 10% of ovarian cancers are familial and they are seen a decade earlier, right? So they usually seen around 50 to 60 years of age. Now, what are the genetic associations? BRCA1 and BRCA2. Highest is with BRCA1, okay? So highest is going to be with BRCA1, okay? What should you do if your patient is BRCA1 and BRCA2 positive? What should you do? These patients should undergo prophylactic BSO, bilateral salpingo-oophorectomy, when as soon as family is complete. So as soon as family is complete, we should be doing a prophylactic, BSO. MEEGS I have already covered. So please remember, as I said, the main one is fibroma. Fill up the others. I said Brenner's, granulosa and thecoma. Okay. Chalo. Quickly, disorders of vaginal discharge. So vulva and vagina. Okay. Now, remember, out of all these, bacterial vaginosis is the most common one and it is not a sexually transmitted disease. This is going to be really quick. I know you know this. So let's do this. Okay. Which bacteria is replacing the lactobacilli? Yes, it is going to be Gardnerella vaginalis. Okay, so it is going to be Gardnerella vaginalis. Okay. Now, most common complaint is vaginal discharge, but it has to be foul smelling. Okay, it has to be a foul smelling discharge. It is gray in color. Sometimes they write it as off-white. Okay, remember what I've written here. Itching is absent, burning is absent. Alright. Chalo. Now, vaginal discharge, as I said, is gray or off-white in color. Please remember, the pH will be less than 4.5. It has to be less than 4.5. Whiff test, you should know, is done with 10% KOH. It gives an amine odor or a fishy odor. What is the classic finding on microscopy? Clue cell. Do you remember what is clue cell? Epithelial cell studded with bacteria. Yes. So please remember, it is vaginosis. So WBCs are not seen. Okay. You don't need to do the staging at all. I just told you, only focus on, cervical cancer staging just once. Don't worry about it at all. Okay. Amsel's criteria may we need any three. So it could be the foul smelling discharge. What are the other criteria? Clue cells, then pH and KOH test. These are the four, out of which we need any three. Yes. pH, sorry, my fault. pH has to be more than 4.5. Yes. An error from my side. I've corrected it. Write it. Yes. Management. Kit 6 nahi hai. What is the management? Batao, what is the management? Yes, pH more than 4.5. Done, done, done. Okay. Done, done, done. So now tell me, management ke liye kya hai? No, it has to be kit 2. Alright, it has to be kit 2 and it is going to be green. Okay, so kit 2 is green in color. What does the kit 2 have? Secnidazole and what else? Fluconazole, right? So secnidazole and fluconazole. Chalo, trichomonas batao. What is the kind of discharge? It is foul smelling, but please remember, when it comes to be discharged, it is associated with maybe pruritus, maybe even dyspareunia, maybe even dysuria. So these symptoms are present, okay. The discharge will be described as green or yellow in color, and as I said, it is foul smelling. pH again has to be more than, okay, pH is more than 4.5. Yes, so pH is more than 4.5 here as well. What is the characteristic appearance? Yes, you all know it. So strawberry cervix, right? So strawberry cervix. Yes. Okay. You will see the motile trichomonad. It is a pear-shaped organism. So you see the flagella there. Please remember WBCs are more here. Okay. Now, kit again remains the kit number 2, same as bacterial vaginosis, because that is the kit for vaginal discharge. But please remember, any time we say vaginal discharge, but on speculum examination they write abnormal cervix, then this has to be taken as cervicitis, right? What is the kit for cervicitis? Kit 1. Yes. So kit 1 for cervicitis. What is the color? Gray. Yes. Gray. So please remember this, vaginal discharge, but if they give you abnormal cervix, it is cervicitis. You will change the answer to kit number 1. Yes. In general, if we ask you drug of choice for bacterial vaginosis or trichomonas, then the single best answer is metronidazole. But in India, we give it as a kit treatment or a syndromic treatment. Is that clear? Chalo. Candida. So what are the risk factors? We've already given you. But remember, the most important complaint here is pruritus. It's not discharge. It's actually pruritus. Color you all know is curdy white. Yes, it's a curdy white discharge. But very, very important, it is not foul smelling. Okay, the discharge here is not foul smelling. pH less than 4.5, right? You can see pseudohyphae, you can see WBCs. There is a lot of inflammation when you do a microscopy, right? The kit treatment remains the same, but if we ask you individually drug of choice, then it is fluconazole, okay? Then it is going to be fluconazole, right? Physiological discharge. Please remember, this is because of the hormones, primarily estrogen, which increases cervical mucus secretion. Now, there will be, the discharge tends to be watery, but most importantly, no burning, no itching, no foul smell. The discharge tends to be clear. Sometimes they may write white. Okay, so sometimes they may write white, but it should be no burning, no itching, no foul smell. Is that clear? pH will be normal. Local examination will be absolutely normal. Okay, so remember that. I just told you, if you see a cervical erosion or ulcer, then you have to give kit 1 instead of kit 2. So then you have to take it as cervicitis. What is the kit for lower abdominal pain? Jaldi se batao. Yes, it will be kit 6. It is yellow. So this is for lap or lower abdominal pain, which is what you see with pelvic inflammatory disease. Is that clear? Treatment of partner. So please remember, because bacterial vaginosis and candida, okay, they are not STD. So treatment of partner is not done. Okay. So treatment of partner is not done in these conditions. The typical answer will be bacterial vaginosis as single best. Okay. Now, a few things that you should know about PID, क्योंकि नीट PG वाले पूछते हैं. Organism का single best answer है chlamydia followed by gonorrhea. Okay. LAP is lower abdominal pain, बच्चा. Okay. Age typically seen in younger girls, 15 to 25 years. Highest risk is with multiple sexual partners. Okay, so highest risk with multiple sexual partners. If you have to answer one thing that is protective, then that is going to be barrier contraception. Okay, so that is going to be barrier contraception. Chalo. Key findings: lower abdominal pain with adnexal tenderness, uterine tenderness, or cervical motion tenderness. So if any of this is present, this is PID. If your patient with PID has upper quadrant pain, then the diagnosis is Fitzhugh-Curtis. Okay, then the diagnosis will change to Fitzhugh-Curtis syndrome. Okay, now what is the characteristic finding on laparoscopy? Violin string adhesions. Yes, so there will be violin string adhesions on laparoscopy. What is the best investigation for PID? Laparoscopy. Very often your exams will ask long-term complications. So the single best answer is infertility. Then comes ectopic pregnancy. Then comes chronic pain. Okay. Then comes chronic pelvic pain. So these are some of the important long-term complications with PID. Take care. All right. Now, yes, they will put the PDF. Don't worry, it will take some time, but they will put it for you as it is. Chinta nahi karo. So, pelvic organ prolapse, nutshell mein karenge, jaldi se khatam karenge. Okay. Now, please remember, when you say pelvic diaphragm, it is levator ani. Very often they are asking you its components. You should know it. Please remember, the component which is contributing to prolapse is puborectalis. So if you damage puborectalis, it leads to prolapse. Okay. The ligaments we have already done. So the best answer is cardinal. But apart from that, uterosacral. Right. So apart from that, uterosacral. Is that clear? Chalo. Cystocele, remember, is the most common type of pelvic organ prolapse. And it is bulging from the upper 2/3 of anterior vaginal wall. Okay, so upper 2/3 of anterior vaginal wall. Rectocele is lower 2/3 of posterior vaginal wall. Okay. Now, the method which we use is called as POPQ, and the reference point is hymen. There is no need to go and do the details of POPQ classification. It is not required. Most of the times in your exams, they're asking you the names of surgeries. So quickly, for cystocele, what surgery do you do? Anterior colporaphy. Okay. Rectocele, posterior colpoperineoraphy. Right. For enterocele, what do we do? McCall's. This is together often called as PFR. Pelvic floor repair, right? Okay. What is the surgery that you do for vault prolapse? This is the most important one currently. So, vault prolapse के लिए abdominal surgery है sacrocolpopexy. Okay? Sacrocolpopexy, it is the best surgery for vault prolapse. But the vaginal surgeries are the ones which are more commonly done. Which ones? Uterosacral suspension. What is the other one? Sacrospinous fixation. Okay. So uterosacral suspension and sacrospinous fixation. Now I want to know from you, can you do an obliterative procedure for vault prolapse? Yes. Obliterative hai Le-Fort colpoclasis. Obliterative procedure can be done for any type of prolapse. But when should we do it? When should we do it? So remember, we will do it when the patient needs a short surgery. Right? So if she needs a short surgery, that's when you will do the obliterative procedure. Is that clear? Okay. Now, if the woman is in reproductive age group, the surgery has to be sling surgery. It is Shirodkar's. Remember, it is a abdominal sling surgery. Okay, it's an abdominal sling surgery. Now, so things that I have given to you, it's important. When you talk about sling surgery, the uterocervical length should be normal. We say it should be approximately less than 12 centimeters. Okay, because if the uterocervical length is longer, right, then you will do Fothergill's repair, right? Where else do you do Fothergill's? When the family is complete. So for Fothergill's, family should be complete. You will not do Fothergill's if childbearing is desired. So remember, long uterocervical length and family complete, we will do Fothergill's. What is the other name for Fothergill's? Manchester. Right? So it is also called as Manchester repair. They are the same thing. Okay? Okay. When do you do or use a pessary? Please remember, pessary can be used for second degree prolapse. It can be used for patients who are inoperable, patients who have prolapse in pregnancy or purpurium. Okay? So if they have pregnancy, prolapse in pregnancy and purpurium, then again we can use a pessary. So remember the indications of pessary, quite often they come in the exam. See? Okay. Quickly, urinary incontinence in short, which is the most common type in younger women? Stress urinary incontinence. Okay? Now, the reason is hypermobility of urethra. Right? So, hypermobility of the urethra. What is the gold standard surgery? Birch Colpo suspension. बहुत बार एग्जाम में पूछते हैं. Please remember, Colpo suspension is not a surgery for vault prolapse. That's where they confuse you. It is a surgery for SUI. Okay? Acha, somebody is asking, when do we remove the pessary? 16 to 18 weeks. That's when you remove the pessary. Okay? Treatment of choice are TVT or TOT. They are examples of what? Mid-urethral sling surgeries. Okay? They are examples of mid-urethral sling surgery. Okay? Chalo. VVF. Most common cause in developing countries is obstructed labor. Patient will typically present after 7 to 10 days. It is never a immediate complication. It is a late complication. Okay. Shreya, 16 to 18 weeks beta. Okay. Now, there is continuous leakage of urine if there is a VVF. But what you have to remember is there is continuous leakage and no normal voiding. So in VVF, episode of normal voiding is not there. If it is ureterovaginal, then there is leakage as well as normal voiding. Okay? Now, diagnosis के लिए क्या करना है? 3 swab test. Okay? So investigation of choice is 3 swab. Okay? TOT, transobturator tape, transvaginal tape. Okay? So transvaginal and transobturator tape. They are vaginal surgeries. Alright? Repair is done after 3 months. Okay? 3 months. Now, remember, surgery of choice is going to be Latsko. It is a vaginal surgery. Remember, catheter is put for 14 days. That's the single best answer. Intercourse avoided for at least 3 months. The range is 3 to 6. And pregnancy minimum time to avoid is 12 months. The range is 12 to 24. Okay, so the range is 12 to 24. Reattempt is only done after 3 months, right? So reattempt of repair is done after 3 months. Is that clear to everyone? Moshkovitz कोई पूछ रहा है. So बच्चे, Moshkovitz, okay, and Halbane's repair are old surgeries for enterocele. Okay, not for VVF. They are old surgeries for enteroseal. We come to the last section and we'll take only 10 minutes and quickly wind it off and then give you a lunch break. Okay, just bear with me for next 10 minutes. I'll wind it off quickly. Okay. Please remember the main function is inhibition of ovulation. Okay, inhibition of ovulation. But it does a lot of other things also. So sperm mobility, implantation, all this is also affected. Tubal motility is also affected. Okay. Absolute contraindications must know hai. So any patient who has coronary artery disease, venous thromboembolism, ठीक है, active liver disease, ये बार बार एग्जाम में आ रहा है, please know it. Diabetes only if it is with vasculopathy. Okay. Migraine if it is with aura, they may write focal neurological deficit. Okay, smoking and more than 45 years, hepatocellular adenoma, right? But active liver disease of any kind is a absolute contraindication. Okay? Now, please remember this is the new pattern of MCQ that is coming. Non-contraceptive benefits, right? So we all know it reduces menstrual bleeding. Okay? It will also be useful for hyperandrogenism or hirsutism. Very, very important. It reduces which risk? VTE is venous thromboembolism beta. Okay. Venous thromboembolism. Okay. Now reduction of which two cancers? Very, very important. Endometrial cancer and ovarian cancer. Okay, so reduction of endometrial cancer and ovarian cancer. Anytime there is heavy bleeding, whether it is because of fibroids or it is because of adenomyosis, right? You can use it to reduce the bleeding. Okay. Colon cancer, yes, it does reduce, but you know, absolute reduction kitna hai, that no one knows. So the single best answers are endometrial cancer and ovarian cancer for risk reduction. Okay, is that clear? So please know this. They are important, which are non-contraceptive benefits. Also remember, when I say hirsutism, they also reduce acne, right? So they will reduce acne. Is that clear? Okay, good to go. Now, your exams have been asking about missed pills. Yes, missed pills. Now, please remember, this is the most important one and these are the guidelines that you're supposed to follow. Okay. If your patient misses 3 or more pills, it totally depends on when is she missing it. Okay. So it depends on when is she missing it. Now, if she misses this in the first 2 weeks, okay, first 2 weeks, then she has to take the most recent pill. She has to continue the remaining pills and she is asked to use barrier contraception. If there is unprotected intercourse, she will also use emergency contraceptive. What is the difference? What is the difference? The difference is the 3rd week. Okay. 3rd week is the risky time. So if she misses it in week 3, that's what I want you to understand. You will do all the above, right? Which means she will take the missed pill, she will continue the hormonal pills, she will use emergency contraceptive, she will use barrier, but please read this. She has to discard the pill-free period or the non-hormonal pills, right? So she has to discard all the, okay, non-hormonal pills. And she has to start new pack, okay, she has to start new pack from the next day itself. This is the only difference, right? So that is the only difference. If she is going to miss it in first 2 weeks, there is no need to discard the non-hormonal pills. But if she misses in the 3rd hormonal week, right? So week 3 is the 3rd hormonal week. Then she has to discard the non-hormonal pills and start the new pack from the next day. Is that clear to everyone? Yes, is it clear? Okay, so missed pills, please ensure that you know it, and these are the guidelines that we follow. Just smaller parts that we need for the others, okay? No, in third week, no new pack bache. Please samjho. Third week mein, she has to continue the hormonal pills. She has to discard only the non-hormonal, which is the iron tabs, right? So she will use the hormonal pills, discard the non-hormonal and start a new pack immediately next day, okay? Start a new pack immediately the next day. Is it clear? Okay. Please remember they are called as mini pill. Okay. Mini pill. They have to be taken at the same time every day. What is the safe period? Their safe period is described as 3 hours. Okay. Safe period is described as, alright. Hanji. So they're called as mini pills. Okay, and I said they have to be taken at the same time every day, okay, and their safe period is 3 hours, okay, 3 hours. Now, please remember the most common side effect is irregular bleeding, okay, the most common side effect is irregular bleeding, okay. The main mechanism of action is alteration of cervical mucus. Please remember, they do not inhibit ovulation. Okay, they do not inhibit ovulation. Contraception of choice for lactating women. Okay, they are the contraception of choice for lactating women. What is an absolute contraindication? Pregnancy, breast cancer, active liver disease. Right? So pregnancy, breast cancer, active liver disease are absolute contraindications. Is that clear? Safe period ka matlab hai beta, if she takes it within 3 hours, then it's okay. If she forgets for more than 3 hours, then she has to use a backup method of contraception. Okay? Backup method of contraception. Okay? Chalo. IUD ka main mechanism of action is inhibition of fertilization. But yes, they will also inhibit implantation. Please again remember, they do not inhibit ovulation. Please don't do this mistake. They do not inhibit ovulation. Okay? Now, absolute contraindications of IUD come repeatedly in the exam. So, undiagnosed bleeding, active pelvic infection, okay? Distorted uterine cavity. The reason for distorted cavity could be anything. It could be fibroid, it could be Mullerian anomalies, it could be a polyp, right? But if the cavity is distorted, you can't read it. I mean, you can't use it, right? Please remember, Wilson's is a contraindication for copper-T. Breast cancer is a contraindication for Mirena. Please remember, dysmenorrhea and dysmenorrhea and menorrhagia are also contraindications for copper-T. They are contraindications for copper-T, not for Mirena. Okay. Now, please remember, one of the most important non-contraceptive benefit of Mirena is it is used in endometrial hyperplasia. So, whenever you have to reduce menstrual bleeding, okay, so whenever you have to reduce menstrual bleeding, Mirena is very, very effective, provided the cavity is normal in shape. Is that clear to everyone? Okay. Now, a few things that we need to know about tubal ligation. We have done this. What is the site? Come on, everyone, tell me. What is the site? Isthmus. Please remember, it is effective immediately. When you call it as, when you do a laparoscopic tubal ligation, remember this is what is called as interval tubal ligation, and it can be done within 7 days of the menstrual cycle. Actually, this is the ideal time to do it. Ideal time is within 7 days of the menstrual cycle. Okay. Consent of only the client is required. Spouse consent is not mandatory. Postpartum ligation is done with modified Pomeroy or mini laparotomy, and it has to be done within 7 days of delivery. Okay, so it has to be done within 7 days. I've just given these images, so you should know, have a general idea. Some students get confused between Pomeroy and modified Pomeroy. So this is Pomeroy when you ligate singly at the base. If you ligate separately, this is modified Pomeroy. Here you use chromic catgut in Pomeroy, okay, and in modified Pomeroy it is plain catgut. Crohn's has been a previous year question, so you do fimbriectomy here. The only one place where you do a crushing, okay, crushing is only and only done in Madeliner's, okay, only and only done in Madeliner's method. Alright. This is again something that sir will cover, but yes, please remember that this is a tubal ring applicator, right? Used for tubal ligation or laparoscopic tubal ligation. And this is used to put the fallope rings as mentioned here. Okay. Now, a short note on WHO emergency contraceptives. So most effective in general is copper T. But if we ask you hormonal most effective, so within hormonal it is ulipristal. Alright. Hormonal ECs act by delaying ovulation. They actually delay the LH surge. Okay. They delay the LH surge. Okay. Copper T will as usual act by inhibition of fertilization, followed by, as I said, implantation. Okay. Doses are important. For ulipristal, it is 30 milligrams single dose within 5 days of unprotected intercourse. LNG tab, 1.5 milligrams single dose or 0.75 divided dose 12 hours apart. Okay. लेकिन better कैसा होता है? Single dose. So 12 hours apart twice. Please remember, LNG should be taken within 3 days of unprotected intercourse. Okay. So for LNG, it is within 3 days of unprotected intercourse. Okay. USP regime is the one with combined OCP. So remember, each has a dose of 100 micrograms of ethinyl estradiol and 0.5 milligrams of LNG. Okay. And again, this has to be taken 12 hours apart. Most effective hormonal, I said, is ulipristal. Then comes LNG tab. Okay. Please remember, they do not have any contraindications. UPT is not required. A prescription is also not required. They are over-the-counter drugs, right? So these are the most important things that you should know with respect to ECs. Now, since I've covered up, tubal ligation, just know these points about vasectomy and then we are done. Remember the most important thing, that it is not immediately effective. Okay. A backup method is needed for 3 months. You have to demonstrate azoospermia in the semen sample and it takes almost 20 ejaculations, right? The method we use is non-scalpel, okay, non-scalpel vasectomy. And remember, the most common side effect is hematoma formation, right? So these are the key points that you should know as difference between vasectomy and ligation. Which one is more effective? That's the last one I want to ask you. Vasectomy. It has a failure rate of 0.1%. Ligation का कितना होता है? 0.5%, right? 0.5%. Okay. Yes, we are done. We are done with both these sessions, obstetrics and gynecology. I'm sorry it took some time and I know you're hungry. So you will get a lunch break now, and then we will continue with the image sessions. Somebody is asking about the OC pill. Beta, maine bola, if 2 or more pills are missed, then she can continue as it is. Take 1 pill as soon as she remembers. The rest will be continued as it is. Okay? If she misses 3 or more, it depends on when she misses it. If she misses in the first 2 weeks, then the answers are same. Take 1 pill as soon as you remember. Continue the pack. Use backup method of contraception for 7 days and use emergency contraceptive. Then I said if she misses it in the 3rd week, तो ये चारों चीजें तो करनी है. Backup method for 7 days, emergency contraception, take 1 as soon as possible. But उसके अलावा in the 3rd hormonal week, continue the hormonal pills, finish the hormonal pills, but don't take the non-hormonal. So there will be no pill-free period. She has to immediately start the next pack. Okay? As soon as she finishes the last hormonal, she has to start the next pack. Okay? Chalo. Take care, everyone. It was a pleasure. I hope you find it high yielding. I hope you find it useful. As I said, you wouldn't really need anything else apart from this once we are done with DVT. So use this and your entire revision is complete. We'll give you a lunch break and then we will have an image-based session. So I think we will restart the class at around 4:15. Okay? So 4:15 we will restart. Till then have your lunch break. Dr. Anil will be taking your image-based session for obs and gynae. Okay? Thank you so much everyone. Again, apologies for stretching it, but it was a pleasure and thank you for giving me an opportunity to be a part of your journey. All the best for your exams and I'm sure you'll do exceedingly well.